Hello, and a very good morning to you all from us here in Goroka, Goroka, Eastern Highlands Province. To the IMR staff over in the auditorium, good morning to you and our partners joining you. Over to Port Moresby, Dr. Laman and the POM team, good morning to you all and our partners joining from there. To our team in Madang, Dr. Timinau and Dale and Betwell, and our partners joining the Madang team, welcome and good morning to you all. Also to our East New Britain team, we know we have our partners with the team in Kokopo, and so a shout out to you all, good morning. And partners from East Sepik and our team in East Sepik is, as well as Milan Bay Province. And to all the IMR staff, wherever you are joining in from across the country, welcome to this session today, this morning, and good morning to you all. My name is Maria Ome-Kaius, and I am a research fellow and the head of the vector-borne diseases unit here at the PNGIMR. Today, you will see a lot of me here with Professor Pomat, but we have a big team working behind the scene who will be supporting us throughout the day. And we hope we can make today a memorable one for us all. Special mention to Dr. Anne Larsen, Mr. Joseph Fryer, Dr. Gwen Vengia, Dr. Barne Willie, Ms. Sarah Javati, and Mr. Ricky Proud, and others. I also want to take this opportunity to thank the Buttressing Coalition and the PNGIMR Executive Management for supporting this important event. With that, I welcome you all to the 4th Annual Virtual Symposium 2024. The theme for this year's symposium is Empowering Health Through Research. And today we will hear all about this through the presentations, interviews, discussions from PNGIMR scientists, clinicians, field teams, and our research partners from both within PNG and abroad. Please feel free to make comments, ask questions, or provide feedback on the chat line, and we have this hardworking team that will help us to get back to you and provide some feedback if we must. Without further ado, I will now pass it on to Professor Pomat, Director of the Institute of Medical Research, to welcome us all. Thank you, Prof.
Thank you, Dr. Ome, and thank you everybody for joining us this morning to listen to some of the work that we are doing and in ensuring that the theme that we have on empowering health through research and some of the evidence that you will see throughout this morning on what that research means and what it will mean for our people. So I want to welcome all of you. This is our 4th virtual symposium held every year for the last 4 years. I want to welcome Professor Seisi Kebao, who's chair of our council, Professor Nakapi Keforani, as well as welcome all of you who are online and here in person. All the staff, like Dr. Ome has said before. So this work cannot be done without collaboration. And so we value the partners that we have with you. And so we thank you very much for coming, joining us for this symposium and ensuring that it works well, but to also understand some of the work that we do here at the Institute. The IMI is now 56 years old. So as you can see, we are a bit older than Papua New Guinea. And like all 6-year-olds, we do have our quirks, but we hopefully that today you will see you will listen to some of the prominent people. So Professor Caroline Homer will present the keynote speech for us, but you will also listen to some of the promising scientists who are coming up. So hopefully through those, we will be able to listen to see some of the great work that we're doing. So with that, I will now pass you on to I hope you have a wonderful day listening to everything that will continue today. And with that, I'll pass on to Dr. Moses Laman, who will introduce 2 of our prominent guests and also prominent scientists in Papua New Guinea. Over to you, Moses.
Thank you so much, Willie. Thank you so much, everyone. I'm privileged to have Dean of the Medical School, Professor Nakapite Forani, who is here with us this morning. He will be giving the opening remarks. And I'm also very honored and privileged to have Professor Seisi Kebao, Council Chairman, with us. And I will now pass on to them.
Thank you, Professor Moses Laman, for that introduction. I'd like to also acknowledge and thank Lady Chair Dr. Maria Ome-Kaius from Goroka. I'd like to acknowledge wider audience that are here with us this morning. I believe we got reps from the National Department of Health that are here with us this morning. I believe there is also reps from the Department of National Planning with us this morning. And more importantly, the PHAs, I think they are with us this morning. I'd like to acknowledge our keynote speaker, Professor Caroline Pomat. I believe you are online today with us, and acknowledge, of course, here in Port Moresby, our council chairman, Professor Saisi Kebao, and our deputy director for IMR, Professor Moses Laman, and also to acknowledge those the different teams, Goroka, which our IMR director, Professor William Pomat, and your team, the team from Madang, I believe is on, as well as the team from Kokopo and Civic. Thank you for listening in from this morning. I'd like to acknowledge distinguished scientists and professors that are here with us this morning. IMR research partners, institution in country and overseas countries, and our distinct guests and colleagues, ladies and gentlemen. A very good morning to you all, those who are physically here and those who are online. I am pleased to be here as a friend and a partner from the School of Medicine, and of course as a member of IMR Council, to attend and the viewing of the IMR 4th Annual Virtual Symposium. So it is indeed a great honor and pleasure to be here today, address you with brief remarks, and more importantly, attending to the IMR's 4th Virtual Symposium with a very important theme, which is empowering health through research. A brief background on the current milestone of PNGIMR, the virtual symposium series that started in 2021, and this is now the 4th to be held. I have been informed and delighted to hear and say that the virtual symposium has attracted over 300 registered viewers, and with many more watching in groups. I believe the group from the School of Medicine is also watching. I was informed that when you started, most viewers were in Australia, but now a large group from PNG. And I believe in this year's virtual symposium, you are also inviting the partners that we have just announced this morning. Ladies and gentlemen, I believe PNG Institute of Medical Research is the oldest professional and scientific research institution in Papua New Guinea. But today it has flourished, transformed, and transitioned itself into one of the most vibrant and national and international professional research institute in our developing country and in the Asia Pacific region and the world. It is the longest established professional research group in this country. It certainly has impressive track record, and institution played a major role in the first symposium in Goroka in 1965. I firmly believe that the institution and its research partners have always been successful in research work and have maintained a very high standard scientifically, medically, and socially. For instance, supporting the trilateral program, malaria program for NDOH, and likewise the STRIVE program for NDOH, and supplementing all the institutions in the country. I congratulate the PNGIMR for sustaining a high standard of research work for over many years, and today is another milestone achievement in that now part of the history of the institution. It is now more than 50 years, I believe it's 60 years, of PNGIMR's existence with the PNG Medical Journal that it coordinates. Both celebrated their anniversary in 2005 in Goroka. I am pleased and proud of the step they have taken with CSIRO by now publishing the edition online. The journal is now an international referee journal. I congratulate PNGIMR Director and all your members for maintaining and sustaining that excellent standard. Distinguished guests, ladies and gentlemen, the medical fraternity needs your support to the current PNGIMR team led by Director William Pomat and Deputy Director Professor Moses Lama. I take this opportunity to congratulate the directors, Professor Pomat and Laman, with the executive team and former director executives for their tireless effort in sustaining this very high standard. Ladies and gentlemen, I believe the leadership of PNGIMR is in good hands, and I am sure future plans would further advance this prestigious institution. For instance, we have large number of researchers and clinical researchers who have risen through the institute and now running research program and contributing to national and international knowledge. Currently, there are at least 9 PhDs from PNG working in PNGIMR and another 12 enrolled in PhD studies. It is my sincere hope that your theme, deliberation, aspiration through this year's program shows that our research, discussion, recommendation will cover the wide range of disease and methodologies. That you will also highlight the range of PNG international researchers and support the staff that will involve, including work and importance of nurses, community health workers, church health workers, laboratory technicians, drivers, as well as doctors and researchers. Distinguished guests, ladies and gentlemen, I warmly welcome the many of you who are today and overseas health workers who have come for this special online virtual symposium. To end, once again, my pleasure to have been invited to open and say a few words in this virtual medical symposium. Thank you and God bless you all.
Thank you, Prof. Tefarani, now I'll pass it on to Prof. Kewau to give his welcome remarks. Thank you.
Dabanamana in Motu. In English, you say good morning and welcome. There's a lovely introductory remark speech from the gentleman on my left, who's also a fisherman. I remember I remember a very important scientific person called Sir McFarlane Burnett. And I remember him going to my village called Pari, because in my village was another white man living. His name was Professor Ian Maddox. Professor Maddox is still alive. He's on his way to 93 years old. So those two people gave me the history of the beginning of PNGIMR, starting in Kakar Island in 1968. So you've come a long, long way. And you look at, when I look at the topic today, it says empowering health through research. Congratulations, PNGIMR, in every respect. In every respect, I'm very proud to say to my colleagues everywhere in the world that PNGIMR has done just that. Right from the beginning, when a disease called Kuru was discovered. And then there were all those research activities that went on and on and on. And there was the sending of specimens all the way to the United States of America, which finally came to the conclusion that this is how this particular disease came about. Then there was malaria, the research into malaria that went on and on and on. In particular, the discovery of this big spleen syndrome, called tropical splenomegaly syndrome, a syndrome that is very unique to Papua New Guinea. And we still see those cases in some of our morning sessions with medical students and registrars. So those are, and PNGIMR has done very, very well on that. So microorganisms that are responsible for the ongoing diseases like what we see now. And like I've said before, since independence, this new disease called lifestyle disease has come on. And when we look at it, it's really terrifying. And there are certain behaviors in Papua New Guinea that need also to be researched into. You know, I drive on the Taurama Road every morning, and as I drive in and out, there are kids on the streets selling bilnut, water, and tobaccos and everything. I go to Koki every weekend to buy some fish. Instead of going straight to the fish market, my wife sees me very angry because there are kids and there are people who are selling all these things. And the way these have contributed to the development of lifestyle disease here. And we see lots of cancers in our morning session from the cancer unit of bilnut-induced thing. And also, like I've said before, bilnut-induced acute myocardial infarct is a real entity. So when you look at all of those, the PNGIMR has done very, very well in its efforts to do research into the lifestyle, to the infectious disease. But like I've said before, I challenge you, and this is another road that you have to look into the future, as I think about retiring at the end of this year. And I really want to retire. But I'm very proud when I retire to say to whoever that I've been very proud of the way in which the PNGIMR has evolved over the years. And I'm sure that you will continue to lots more. And with those opening remarks, I congratulate the director and also Dr. Laman here. I rang this morning and joked about Dr. Laman and Lamana, and I wanted this to have any relationship in that name, but he said, no, I'm Laman. So enjoy your meeting. I'm sitting in Lamana Hotel, and I look forward to hearing some of your discussions before I go to my Year 5 teaching at about midday. Thank you very much, and welcome, and keep going. I'm very proud of all of you. Thank you.
Okay, thank you, Professor Keval, and thank you, Professor Teforani. For our next speaker, we are honored to have Dr. Osborne Liko, Health Secretary for the National Department of Health, here to join us. And and be part of the symposium. Dr. Liko is also a valued member of the PNGIMR Council. In the interview with Dr. Laman, Dr. Liko reflects on IMR and health research, as well as his role as a member on the IMR Council.
Well, first of all, Secretary, thank you so much for making time to come for us to interview for the virtual symposium. We really appreciate the time you have given for us to come. The first question I would like to ask you is your perspective about the Papua New Guinea Institute of Medical Research. Thank you.
Our Institute of Medical Research is the only Institute of Medical Research in the country. It carries the flagship of the research in the country. And when it got started in 1968, our mentors and those that were before us, maintained that high caliber of our institute. And if I can also emphasize and proudly make mention of the records of what the Medical Research Institute had been and has been our flag carrier in research in medical, the field of medicine, starting with the guru. And of course, I forgot the medical terminology of that, something, that, it actually was the first in the whole entire world. Our PNG, even we're still developing in every other aspect of development, IMR and research, and the guru, hit the international journals, and that actually raises the flagship. Also, when you look back to Big Bell, and rightfully from Goroka in Timbi, with this diet and how we had this, the enteritis, colitis of the kids and newborn, and our surgeons were there, and having that experience, it was IMR into the research that actually brought even again another flagship in ways. Had the literature and from our research, or our pioneers, our mentors, maintaining, carry the flagship of PNG, research and also the health sector, and how we have come this far. And over the years, what IMR has done with all our mentors and the research, great medical research, the staff we had, and of course we had, in terms of the leadership, in terms of maintenance, in terms of maintaining the stability. And I think IMR of all other councils, of medical councils or medical committee institutions I have known from our history when we were medical students up to being a doctor. They maintain stability of the council with Professor prior to Saweri, Professor before Adolf, who was taking 20 years as the director.
Professor Alphas.
Yeah, Professor Alphas. Then, when coming on to Professor Saweri, before Professor Saweri, also we have also nationals, Professor Peter Siba. So it has this very important stability and supporting the research in all clinical fields, plus also the research in a lot of other infectious diseases and mobilities of the disease that we're trying to get to know the causative, the factors, for example, with vectors in malaria control and what IMR has done, and pneumonia with children, with high incidence, morbidity and mortality of pneumonia. So a lot of this work, it really puts IMR, on the, not in PNG only, in international, forums and publicity journals. And over the years, you and I would know, being students up until, when we became doctors, and you yourself joined IMR, which is also, something of pride to all of us. And the research that IMR has continued to do, and medical symposiums. that we would have, in fact, IMR would, dominate in the rest of the presentation, but for all of us, it's also as part of the medical education continuation when we had the yearly symposium. So in a nutshell, that's how IMR has maintained a high standard of research and support the clinical service, and in supporting us in finding some solutions to helping us in the morbidities and mortalities of malaria and pneumonia we have in the country. I think I'm talking too much.
No worries. Thank you, Secretary.
Yeah.
You are also involved in the IMR Council, and have been involved in a lot of important decisions for the governance of the institute. So, would be great to hear some of your opinion about your involvement in the council. Thank you.
Thank you. And by virtue of the position, and I'm thankful about in our constitutions, that by virtue of the position as the health secretary, that I am the member of the IMR Council, and I'm fortunate, and of course I maintain that high standards of the council, and I have a high regard to the council, and I make sure that with consultation with Joseph and Director Professor Pomat, if and again I like the flexibility of our council, having Vice Chancellor, PNGIMR, myself, and of course the Dean of Executive Dean of Medical School, and now we have the Vice Chancellor of PAU. So we have a very high caliber members of the IMR Council, and any meeting and every meeting, and of course I'd say EC being our chairman, that we always maintain high regard to the council, and I want to make sure that then by WhatsApp that we have formed, and I want to make sure that we communicate to make sure that if any meeting schedules, I want to make sure that I'm there. If for some reason I really cannot make it, and we do communicate to make sure that my proxy, somebody next senior to me, like deputy secretaries, to attend the IMR Council. And let me say this, without having any embarrassment to our director, Professor Pomat, that's how important IMR Council is, and put into the perspective examples of when the position for the director of IMR was advertised, and our director, congratulations to the director, Dr. Pomat, Professor Pomat, the fact that he was acting, and again his perseverance and his humility to continue to work when we were going through the process of having permanent appointment. And this is when we appreciated through the process of appointment. The DPM, of course, when they were screening for the appointment of the director of our Institute of Medical Research, there was only one applicant. And of course, he was the only one that qualified, apart from yourself, because you're also coming up the rank and file. And of course, DPM couldn't accept being only one director to, by the way of the recruitment process. It did not comply with the public service, the recruitment process. So the discussions, in fact, it went on for almost 1 year, 6 to 9 months. And they were saying in response to IMR Council through chairman that we will put that director into administrative positions. And during that time, we had a council meeting in Madang. I was a little bit late in the flight, but it's how we value each council member. The chairman had to wait until I got there. So we had a resolutions that chairman and myself represent the IMR Council into having some discussions with the secretary for DPM. And we did the following week. This is how we have actually, with DPM didn't know the significance and importance of the director of IMR. I said it during our discussion, I said, if Professor Pomat is the only candidate, so be it. We can't dilute that to anybody like any departmental heads or any directors of any other administrative organizations. It carries the flagship. And we in fact educated Secretary Tai Sansan, but to comply with the DPM, to comply, of course we have to go through the Public Service Commission, get another compliance and clearance from State Solicitor to finally accept, for them to finally follow the process of recruitment. Have our director finally appointed, now being gazetted, so congratulations, Professor Pomat. So that's how important it is in our role, how we value this, the IMR and our contribution to it.
Thank you so much, Secretary. So the other question is probably our last one now, about the importance of research and collaboration. Probably what are your opinions, and if you have a recent example you might want to give in terms of how researchers inform locally and global bodies to inform policies. Thank you.
No, thank you, Dr. Lamanti. Deputy Director, I must also acknowledge that. Thank you, YMR. And I'm really proud of Dr. Laman. He was my resident, and being a pediatrician, but when he was actually going into IMR, I was wondering why. But when I became a secretary, and of course before I became a secretary, knowing and in symposium presentations, and his presentation your presentation in the medical journals, and even malaria journals, parasitology journals, that are not only in PNG but overseas. It really impresses, and in fact we also, if you don't mind, I have to say this, that we are proud of you. And in fact, that and particularly I have to make a classic example of the mosquito what do you call it? Bed nets. So, the publicity, even there was some issue with WHO, even in the production for those companies, they were making those bed nets because, of course, the commercial, the productivity, profit margins, they wanted to deny, but thank you, I think three publicities, on the international level, and they've shown the evidence of those chemicals in the bed nets were not effective. And it was not just overnight, you consistently produced the results. And to be honest, when we had a council meeting in Madang last year, going up to the government, seeing your those mosquitoes, and I knew about it, and there was presentations were made in Symposium, but to be there in the government to see all these mosquitoes, what do you call it,
the entomology.
Entomology was very, very impressive, and you saw the demonstration of the bed nets, and it really sort of brings out the importance of the research. And of course we have research centers in Maprik and Madang,
East and
Western Britain. Just at time I would like to, personally would like to visit those places, but obviously we will continue to support wherever it is necessary. And also after Yagam, visiting Yagam, I realized how important it is to have a new lab going up, and I want to appreciate that collaborations. Remember, I think when I took office, apart from our rep from IMR, like I'm the member of the council of the IMR, we have our director, Professor Pomat, being also the member of a National Health Board, which is the hierarchy of governance system of the country. I've actually gone further and made our communications how that important of the collaborations with health, with IMR. I want to get the closer links so that in terms of budgetary support, in terms of that connection with the clinical, with the research, and having that collaborations and integrations. I invited in terms of coming to presentations in the quarterly report. So by mandate of its mandatory support to funding, how we can. So those are collaborations that I wanted to link IMR with the health department and health sector. And going further, let me just have this opportunity to say, going further with the National Reference Laboratory. I've made those discussions. So I want IMR to be heavily involved, and that's in my discussions. And our lab research for the medical testing. And so those, I want to put them all into that integrations and the collaboration going forward. The classic example was during COVID-19, where IMR have come in, having, but of course we didn't have that lab of that dynamic, the technology. So, in terms of research, IMR was involved. Our Prime Minister was directly involved in some of the high-level discussions in terms of the COVID-19 and what research, what we're doing about it, and the value and appreciation of IMR came in a bigger way, in the big picture. So that's establishing and of course putting out the values of what IMR means in terms of the health, and COVID-19 was a good example. So looking at that, going further is I want that integration and collaborations going forward when we have big institutes, like National Reference Laboratory, having our data, the research data, the clinical data, so that it helps us to make big decisions, because the research that, with those data, reflects and indicate onto improvement of the health outcomes. So those are things I want to see that we go forward. And with the lab, new buildings that comes up in Madang, once it's completed, it will start. The moment you have a new National Reference Laboratory, there will be some collaborations. I want to do it in the bigger picture. So we need to move forward in that way. I think I'll stop here. Thank you.
Thank you so much. Thank you so much. Much appreciated.
Great pleasure. Great pleasure.
Thank you, everyone, and thank you, Dr. Liko, for your reflections on the IMR research. Just a housekeeping, if you are losing connectivity, make sure to refresh and get yourself back on. With this, I want to also say hello and welcome to our Madang team, our partners who have joined the Madang team in Madang, Divine Word University, Madang PHA, Tuspab Secondary, and Alexishafen Health Center, and Madang Fire Service. Now, to conclude this first session, if you like, it is with great pleasure and honor to welcome Professor Caroline Homa to the symposium to give a keynote address. Professor Homa is the leading midwifery research in Australia. She has an international reputation as a scholar and leader in maternal and newborn healthcare and service delivery, leading research and development projects in Australia, Papua New Guinea, and elsewhere, especially in relation to health services delivery, reproductive, maternal, and newborn care, human resources for health, workforce development, and midwifery education. She is active at the highest level of research policy in Australia, having served as a member and then chair for NHMRC Council from 2018 to 2023, and internationally as the inaugural chair of WHO's Strategic and Technical Advisory Group of Experts for Maternal, Newborn, Child, Adolescent Health and Nutrition. Welcome, Professor Homa. Thank you.
Thank you so much, Maria, and thank you for that very warm welcome and particular acknowledgement to Prof. Pomat, Prof. Teferani, and Prof. Kaval, who gave such lovely opening addresses. Thank you for the opportunity to speak today. Move my slides along. So I'm in Australia giving this talk. I come to you from Gadigal land, which is in Sydney, but I acknowledge the lands of the Boonwurrung people of the Kulin Nation, where the Burnett office is situated, and pay respects to elders past and present. It's a huge privilege to be invited to give this talk today. Papua New Guinea is an amazing country, rich in diversity, language, history, and culture. And PNGIMR is a very important part of the country, and you've heard about some of the history today already, and I know you will continue to hear more about the fantastic programs through the day. As you know, the PNGIMR logo is a shield, and this shield is symbolic of cover and protection, particularly in warfare. And the IMR logo, Save Tobium Sick, means knowledge prevents illness. And that's a great motto, and one that I know has wide resonance for the work that you do and your significant influence on policy and practice. IMR is at the forefront of learning and translating that knowledge into protection for Papua New Guinea, but more broadly these days for the Asia-Pacific region and globally. So my introduction, Maria gave a lovely formal introduction, but I think a more heartfelt introduction is probably more important at this point. So I was born in Zimbabwe. It was then called Rhodesia, and I come from a very strong colonial family background. Both my parents have colonial heritage, having been brought up in Kenya, in Tanzania, and in pre-independence India. My grandparents are also of colonial heritage. So the issue of colonization is something that I've thought about a lot, and I'm very cognizant of my limitations and my experiences. It has also meant I have a very strong sense of injustice and where I see that things are wrong and things to address and things to fight against. My family are white. This is a photo taken at Christmas last year, just before my father died. And I have had the privilege of working in Papua New Guinea and with Papua New Guinea people for more than 25 years. And I'm constantly impressed with the strength, resilience, determination and wisdom of my PNG colleagues. These days, I work at the Barne Institute. We're a medical research institute and an independent NGO in Melbourne. We also, of course, have offices in Papua New Guinea and in Myanmar. And a special shout out to all the Barne colleagues joining today, especially those across Papua New Guinea. Barne is a proud member of the Buttressing Coalition and a proud partner with IMR in many projects over a long period of time. And I've also been privileged to collaborate personally with IMR over many years. So today I want to talk about why research is important and why it makes a difference. And I guess to start by saying you must think it's important. You are here on a Thursday morning with all the challenges in connectivity, particularly in some parts of the country. So you must think it's important. But I also want to be a bit challenging and talk about how colonization impacts on research more broadly, and maybe in Papua New Guinea, and you'll have to be the judge of that. I hope to be a bit challenging. I hope I can give you some food for thought this morning as we navigate the world of research together. And most of what I'm going to share with you today, I have learnt by working in Papua New Guinea, in the Pacific and across Asia. And most of it is what I've learnt from getting things wrong. And I think we learn a lot from our mistakes and our missteps and our challenges. But I hope some of these reflections will be helpful and maybe will make you think about how can you make your research more effective. So why do we do research? Or why do we care about research? And these are some of my reasons, but maybe they're some of yours too. I think because we're curious, and I started my research career in Malawi, in sub-Saharan Africa, being curious about HIV in pregnant women nearly 30-something years ago. So we do research because we're curious. We do research to learn more, to contribute to knowledge, to work out how to do things better and what to do in a different situation. And increasingly in recent years to disprove misinformation, which has been such a challenge. We're also pragmatic, and we do research because it's in our career structure, it's in our job description, it's what our job says we do. And then importantly, we do research to help government, to help policymakers, to help health service leaders work out what to do, where to put money, where to put investments, where to do policy. I'm sure you have your own reasons for doing research or thinking about research. But overall, I think essentially we do research to make a better world in whatever part of the world we live or work in, and to make sure everybody has access to healthcare and that nobody is left behind. So PNGIMR has been leading research in Papua New Guinea for 56 years. That's an incredible contribution and an incredible feat in a very complex environment. And it has meant a lot of great research has been done, and you will hear about some of that today. And I would like to particularly congratulate the leadership of IMR for this tremendous achievement. There's lots of great research going on now and in the past, and I know in the future. Issues like malaria, anti-malarial therapies, insecticide resistance, especially in children, the burden of chronic infections, lymphatic filariasis, HIV, STIs, child health, maternal health, sexual and reproductive health, and most recently on eradicating cervical cancer. And today you're going to hear a lot about the STRIVE program, which is an incredibly important initiative. So if you added all that up together, 56 years, a lot of research, so much research. Has it made a difference to health and health services in Papua New Guinea? And I'm sure for some topics, I'm hoping for many, you can say yes. Policy has changed, implementation has happened, interventions have been put in place, lives have been saved. But I guess if we were really reflective, for other topics, we might say no. We might say the research practice gap still exists. The research has not been taken up. Changes have not been made, even though we know we have the evidence. And you know that I am a midwife, and I know that mothers and babies still die in Papua New Guinea of things that we know we could fix because we've got the evidence. We know what the research says to save them, but that doesn't happen. And that's a really challenging thing for all of us. And then there's some research that maybe has been implemented or sometimes is implemented. And I think that's particularly down to leadership, down to the context, the more challenging context, it's harder, the available funding. And it does come down to the courage of the providers, the courage of all of you to get evidence into practice, because it means change. And change is really hard. So if I think about why is some research successful and some isn't, and I think about the successes, and for me, this is some of the keys. Doing research on the issues that matter, focusing on the right things. Research that is done by the right people, particularly local researchers and clinicians who know the problem, who have the skills, who have the capacity to co-design and lead the research. We know that research that is well funded and delivered at scale will make a difference. And I've spent most of my career trying to stop doing pilot projects, small projects in one small place that only last as long as the funding lasts. And maybe that's your experience too, but I think we have to step up and implement at scale, not for little projects. We also know that research is successful that has policymakers and health service leaders on board, ready to take up the service, the evidence, ready to use the research. And we know that having a system that's ready to change and the resources to change also makes research successful. And finally, doing the research in partnerships, real, authentic, non-hierarchical partnerships. And that's a challenge for all of us in all of our countries. So I had wanted to think about why research is used successfully in Papua New Guinea. And you know my history and my story. I'm not from Papua New Guinea, so this is in my humble opinion. But how can research be used successfully in any country, mine as well as yours? So this is for you to decide. But in preparing for this talk, I looked at what others in the global health framework global health world have looked at. There's an amazing young researcher called Saya Adimbola. He's a health services researcher from Nigeria who's based at the University of Sydney. And he's written a lot about global health and about decolonisation. And I have adapted his criteria for success in this slide. So for me, being PNG-led with equity at the centre, the leaving no one behind principle. Having research that's locally developed and locally owned with a commitment to be used. is really important. Local capacity must be strengthened and valued. And I was really excited to hear from Prof Teferani the number of PhD students now in Papua New Guinea and PhD graduates. And I congratulate you and encourage more and encourage ways that we can find funding to support more PhD graduates from Papua New Guinea. We have to hear new voices. I do feel, and Prof Kaval said that he was retiring at the end of this year, we all must be thinking about how we can succession plan. Who are the new voices after us? Who are those that can be heard and prioritised and given opportunities? And of course, finally, for research to be successful, there must be these authentic and respectful partnerships. And we have to be prepared to tell each other when we get it wrong and to learn from when we get it wrong, so that we can move forward together. Local leadership is key, and of course IMR has been leading this way for 56 years. But maybe there are other challenges. And Saya Abimbola also has a lot to say about global health research leadership, especially after COVID. So he talks about some of these barriers in other countries, and perhaps they're similar in Papua New Guinea. Perhaps you can take some of these and think about them. So a lack of incentives, particularly at a national and institutional level, and a lack of capacity. A lack of mentorship and support for doing the research, presenting the research, publishing the research. In some countries, there's limited original data on prevalence, management, and outcomes. And I think in Papua New Guinea, this is probably the case for some things, but not for others. You have fantastic data on many issues of prevalence. Having a lack of established research infrastructure, which again, the IMR provides that in Papua New Guinea. Very uncommon in many countries. There is in many countries, though, a challenge of integrating or valuing research culture within organisations. But we know from a lot of evidence that a research-intensive organisation provides better healthcare. And that's not because those patients are in research, it's because everybody's thinking about research. So a research-intensive health service will provide better care. And another challenge is about the lack of data. So electronic medical records are not in routine practice in many countries, and clinicians often don't have protected research time. The funding issue that I've mentioned before, and then the history of colonisation and colonialism and other countries, and I have to confess, sometimes that's countries like mine coming in and taking over. And this is the challenge for all of us. So we have an elephant in the room, which is around colonisation. And maybe this isn't the case in Papua New Guinea, but maybe it still is. So PNG was colonised and has now been independent for 49 years. So next year is a very amazing year for you in Papua New Guinea. Does colonisation get in the way in the research that you do, in the health services that you deliver? I hope I'm wrong whenever I say it doesn't, but maybe I'm also wrong because it does. And maybe there's some things in this diagram that you see in your work. I think the really unique thing about the IMR is that it provides an antidote to some of these challenges, especially a foreign gaze, especially diversity, equity, inclusion. And I hope that there are other aspects in this slide that you can think we can work around and we can work together to make research more successful, and that we can call the elephant in the room some days, and maybe that's helpful. So not everyone likes the term decolonisation, but it's one that's talked about at a global level and perhaps has some relevance here. This is a very powerful quote by Pascal Alotti and Daniel Reedpath from the UN University. Pascal now leads sexual and reproductive health at WHO in Geneva. And they challenge us by saying decolonisation is fundamentally about redressing inequity and power imbalance. And it cannot be achieved without also addressing gender inequity, racism, and other forms of structural violence. And the colonised have to be at least as reflective about the status quo as the colonisers. And this is a pretty challenging quote, I think, for all of us to think about, but perhaps has some relevance. And I think we all need to redress inequity and power imbalances. We can disrupt and dismantle, and I encourage that, but we can't be left with nothing. So we also have to be good at realigning, rebuilding, reimagining, and transforming. And this is the only way we'll get to the next stage, and we have to do this through partnerships. So the issues are particularly equity of opportunity, decentralisation, new models of ownership. We need to think about new ways of doing this work, more opportunities for research training. How can more PNG researchers do the research training they want to, get PhDs, be given those opportunities? And how can we ensure that the research is responsive to the context? How can you make sure that that happens all the time? Everyone must come to the table. So you in PNG must come to the table. You must lead the research. You must lean in to leading the research at the table. Consult early, co-design, work with all of your stakeholders, from the community, the health service, the policymaker, and the funders. The health services, we have to make sure in all the research we do, those of you in PNG, but when I do research in my own country, engage health services early. They don't want to hear about the research at the end when we've got the findings. And then we have to help health services be brave to make change. It's hard to make change. It's hard to redesign the way you think about your care. Policymakers in PNG and in other countries, be willing to work with researchers. We can be a tricky mob. We've got lots of good ideas, maybe sometimes some crazy ideas, but we really want to make a difference. So be willing to work with us, be innovative, mobilise resources and investments. And to my colleagues, our international partners, I urge us to listen, to support, to walk behind and alongside, to engage early, to enable local leadership, to give up power and to lean out. So there's the leaning in and then there's the leaning out. And to funders, and I know we have some funders on the line today, please ensure that research goes to PNG for research and that it goes to PNG to use how it wishes rather than goes to Australia for us to decide. So once we are at the table, so if we bring everybody to the table, we have to recognise our past, present and our future. And not all of it is pretty and not all of it is good, but by reflecting and acknowledging our limitations and our strengths, I think we can move forward. So for some of us, that's about leaning in and contributing more and being more involved. For some of us, though, it's about leaning out and letting others lean in. And I think we all must be accountable to the partnerships and the relationships. And I hope that the courage and the trust and the relationships over the last 56 years with IMR and many, many partners mean that we can do this. So back to my question that Prof Pomat asked me to address in my talk today, in my last slide. How can PNG use research to impact on health and health service? I don't know. I can't answer that. That's for you to answer. That's for you to decide. But for all of us, I think we must and we can partner to realign, to build, to reimagine and to transform so that we can make health service changes and improve health outcomes in real ways. And we all must come to that table to ensure research will improve the lives of people in Papua New Guinea. So thank you very much, Maria. I'll hand back to you.
Thank you, Professor Homa. Very insightful talk, and yes, partnership and coming together to the table is key for any success in conducting research and going forward, and really appreciate those very insightful words from you. just before we move on to the next session, just to shout out to anyone who joined us late after we have started, welcome. And thank you for staying with us and joining us. A special mention to our partners joining from Port Moresby with the team in Port Moresby, namely Burnett Institute, Treasury Department, National Department of Health, NCDPHA, Hola Center, School of Medicine and Health Sciences, and Department of Personnel Management. Welcome and thank you for joining us. Now I will pass it on to Professor Pomat to introduce our next session. Thank you.
Thank you, Maria. And thank you, Professor Homer, for such insightful presentation and thought-provoking as well. So very much like to go with what you just said and come together, work together, and do things together so that we can improve lives through working together. So thank you very much for those insightful words. So our next session is going to be on clinical trials. And clinical trials, as many of you who have done clinical trials know, that it epitomizes research methods that are utilized globally to ensure that new interventions, for example, testing drugs or vaccines or devices or treatment, I use this to be able to then inform us whether that research works or not, or that drug works or not. And so there are separate phases of clinical trials. There's phase 1, 2, 3, and 4, and each of those tests essentially efficacy and safety. And at the Papua New Guinea Institute of Medical Research, we've been very fortunate to be able to have done quite a lot of clinical research or clinical trials so far. And some of those include one that I was involved in called the pneumococcal vaccine trial, which led to the introduction of the pneumococcal vaccine to children in 2015, 2016. And more recently, the IMR has been involved in clinical trials in malaria and so on. And so we've got a lot of experience there. And in this session, we will hear about the STRIVE program and what they're doing in that research space, how they're doing it, how they're engaging with the community, how the ethics of conducting a clinical research can be done. So I now want to introduce Professor John Barne at the Madang PHA, who will provide us with a presentation on some of the work that they're doing there, but also throughout this next session, we will listen to different partners on the work they're doing, as well as staff from the Institute of Medical Research. So I'll pass it on from there.
Greetings and thank you for the opportunity to speak again at this year's virtual symposium, particularly as a partner in a PHA and with PNGIMR and together with international collaborators, especially on clinical trials. We know the importance of clinical trials in low middle income countries, especially when it's tailored towards priority areas where disease burdens are plenty, resource scarcity, remoteness, and isolation is real, coupled with a lack of political will in a country that's also got a low literacy rate. We in Madang have been very fortunate to be involved in a lot of clinical trials, contributing to improving policy guidelines and clinical practice guidelines in this country. And for the country, we have contributed to many research collaborations, particularly with clinical trials. And I will only highlight some recent ones that I have been part of and we are currently running from the recent past. First one is the P trial, which was a study that was investigating the impact of intermittent preventative treatment with azithromycin to standard treatment of sulfadoxime, pyrimethamine, or Fancida for the prevention of malaria in pregnancies. The key message in this was that this study showed that SP and HZ reduced low birth weight in Papua New Guinea. Some of my collaborators included Maria Home, late Regina Wangnapi, Olga Hunga, Stephen Rogerson, and many others. The second trial that I was involved with was the one-time trial. This study investigated the point-of-care testing and treatment across two sites in Papua New Guinea where Madang was the main site. And the key message here was that we looked at the treatment of STIs, and we realized that there was a substantial reduction in the preterm low bed weight patients in the Neisseria gonorrhea subgroup, but not the other STIs. And that study involved collaborations with Michaela Riddell, Alice Mengi, and Andrew Willie, Willie Pomat himself, Lisa, and many others. The other trial is the study looking at misoprostol for induction of labor in this country. Misoprostol titrated and taken orally at 25 micrograms against 12 micrograms. And we have realized that the 25 micrograms was effective and efficient, and women were able to deliver the babies in a shorter period of time. And this study was particularly a main component of my medical doctorate. And that has changed the standard treatment protocol for induction of labor in this country. And some of my collaborators included Moses Laman, Glenn Mola, Elvin Lufele, Paula Howe, and many of my registrars that have come through the department. One of the recent trials is the support trial. This trial looked at sulfadoxime pyrimethamine versus the dihydroartemisinin and piperaquine. The aim of this study was to see if there was improvement in the outcome as was used as a prophylaxis treatment for malaria in pregnancy. And this study had the potential to significantly improve prevention of malaria in pregnancy, because the current standard treatment, which involves Fencida, is not working very well, and we see a lot of malaria relapse and also complications of malaria in pregnancies. And my main collaborators were Olsine, Brian Mo, and Stephen Rogerson. And also, we have been part of the human papillomavirus point of care test and treatment study as well to address the burden of cervical cancer in the country. And the findings from this has been advocated in many different forums, particularly in the medical symposium and many society meetings, and even to the politicians. The key message from this was that from the study yet done from Madang and Mount Hagen, we now have seen that HPV or human papillomavirus prevalence is about 15 to 25%. And so early diagnosis and treatment is very important. And these studies have contributed towards forming as a pillar towards the elimination target for that. And we hope that we can roll this to the rest of the country. And my collaborators were Andrew Walali, Michaela, Josephine Kabuzi, Steve Badman, and Catherine Totona, and many others that have contributed to this. And the findings from this remain an important public health concept that has a lot of interest from many PhDs right across the country, and also politicians as well. And also, following on from this HPV point of care test and treatment, we also fortunate to be part of this GACD grant as well, which the key message from this is the purpose of this is to provide implementation evidence required to inform the scale up of this HPV work that we have done into rural areas, particularly low middle income countries like Papua New Guinea. And here in Madang, we're trying to go up to Bogia, which is one of the remote districts. And we hope that lessons learned from this can be rolled out to the rest of the PhDs in this country. And my main collaborators with this, Michaela, Andrew Malali, and many others that have contributing, and we are collaborating. One of the other recent upcoming study that I will be collaborating with Western Australian-based collaborators, especially Brioni Moore, Lawrence Manning, and Moses Laman. We're trying to look at a trial, trying to see the optimum dosing for cefixime as an alternative treatment to benzathine penicillin for a treatment of congenital syphilis in this country. And we hope this will lead to improved treatment for syphilis in Madang, and of course we can roll that out if it's found to be make that impact. So these are a few of the recent past and current ongoing clinical trials that I have been part of, that we are here doing in Madang, and collaborating and building capacity and providing better evidence-based practice for policy guidelines and improve better health for our people in the country and of course in the region and the world. Thank you.
Thank you, Dr. Bolnga, for the overview of the clinical trials. In clinical trials, getting the support of the health facilities and the clinicians and working in partnership with them with mutual respect and understanding and collective decision-making is key to successfully completing clinical trials and achieving the research outcomes. And not only that, but together bringing this into policies and treatment changes to improve the health of our people in the country. What we heard from Dr. Bolnga are some of the success stories of such collaborations. Apart from his presentation, there are detailed presentations of various recent clinical trials that, excuse me, that have been put together by our researchers, and they will be available on YouTube. And I encourage you all to go and view those presentations by our researchers. These presentations include a presentation by Dr. Michaela Riddle on the one-time study, a presentation by Dr. Alice Mengi on the support study, Dr. Celestine Aho will present on the IMPROVE study, and Dr. Paula Tessine on the study about preventing postpartum malaria. And finally, our collaborator, Associate Professor Brian Moore, presenting on the ultra-short course Primaquine. Please go and listen to the scientists and presentations. On that note, please, can I remind you again, post questions, comments, feedback, and our team working in the back will help us answer some of those chats. Now, in our next segment, we will hear from our research team, famously known as the drug study team for many years now. The team has been involved in many ways, many years of clinical trials, and among some of the most experienced clinical field team within IMR. So this session will be led by Dr. Paula Tessine, one of our IMR's young and upcoming clinical research fellow, who has been involved in a lot of the clinical trials conducted out of the Alexishafen Health Center. We will also hear from Associate Professor Moore, Research Nurse Gumulyadi, and Project Driver Michael Bunan. But we're also very grateful to have joined our team in this segment, and I believe is also present with the Madang team in Madang, Sister Nora Alung, a senior midwife at the Alexishafen Health Center, whom we have worked with for many, many years. Thank you.
Hello and welcome to the Heart of Mary Health Center at Alexishafen. This healthcare facility is managed by the Catholic Health Services of PNG and is the main healthcare facility in a 120 square kilometer area north of Madang town. The catchment area within the vicinity of this facility includes villages from the north coast of Madang district, and it serves a population of approximately 80,000 men, women, and children. The healthcare facility comprises of an outpatient department, a pediatric and adult inpatient ward, a 2-bed acute or trauma bay, and a 15-bed maternity wing and an antenatal clinic. Other services provided by the health center includes a voluntary counseling and testing center, TB clinic, maternal and child health services, and a microscopy lab. In 2003, the Catholic Health Services and Heart of Mary Health Center collaborated with PNGIMR and the University of Western Australia to set up a research site within its premises. In the subsequent years, successful malaria intervention trials and clinical trials, including pharmacokinetic anti-malarial studies, were conducted mainly on young children and the pregnant population of the community. This research site comprises of a basic outpatient clinic and laboratory setup, as well as a separate patient room and kitchen area where participants enrolled in pharmacokinetic studies and interventional trials were monitored overnight. We also have access to beds within the health facility that study participants can use for overnight stay.
The first collaborative IMR UWA paediatric study was started in 2003 based at Modelon Hospital. The success of this study was soon after followed by the establishment of the Alexishafen-based drug study team in 2004. The first study conducted at this site was a randomised control trial in children with uncomplicated malaria, who were randomised to receive either national first-line treatment, which was chloroquine, sulfadoxine, pyrimethamine at the time, or one of 3 artemisinin and combination therapies. The results obtained in this study, which clearly demonstrated the superiority of ACT regimens to chloroquine SP, contributed to data which resulted in the change in the PNG National Treatment Policy of uncomplicated malaria. The overall success of this study, along with the outstanding support of the local Alexishafen community, then resulted in a progression of clinical studies being conducted over the past 20 years, whereby a range of relatively new drug combinations or novel treatment regimens have been investigated. The research team, still affectionately referred to as the drug study team, are renowned for the quality of data they collect in the studies conducted, which, with an average follow-up success of 91% over our range of studies, I think we can all agree that the quality of research undertaken by the IMR team is consistently exceptional. In the past 20 years, a total of 13 clinical studies have been successfully completed by the Alexishafen drug study team, the majority focused on generating PNG-specific data, facilitating dose optimization for infants, children, and pregnant and postpartum women. In 2004, upon the establishment of the IMR research site at Alexishafen Health Centre, the Heart of Mary Health Centre kindly volunteered the use of one of the staff accommodation rooms for the IMR research activities. Since the conduct of that first trial, the footprint at Alexishafen Health Centre for IMR has definitely grown. This has resulted in our research activities having the opportunity to be relatively self-sufficient, housing all required diagnostic equipment required for the varying studies.
Throughout the last 20 years, through our clinical trials, we have worked closely with the clinical staff at the Heart of Mary Health Centre in providing support for optimum patient care in areas of pediatric care, inpatient and outpatient care, antenatal care, and lab support. A huge part of our work also involves community engagements.
Studies I've worked with at the Alexishafen Health Centre is I work with IPTB studies, drug studies, one-time studies, and currently the support studies. I worked well with all these studies, except with the one study that we encountered few challenges. Only few challenges. We have worked well with the other studies that have been stationed at Alexishafen. Together we have been sharing knowledge and ideas together, experiences also we have been sharing together. We participate with the community, share the same knowledge, and we build a network to make the world a better place for our people here.
Kita work as a research nurse, so recruit team participants, enroll all, diagnose all, treat all. Sometimes all participants where me at all randomization bleed, me pas keep all lost sleep, so me pas put all lo L center, Alexishafen L center, and give me one ward, so me pas keep all participants sleep long lo assess all lo night all randomization bleed long all. So misa walk go one them this last something misa looking one them Alexishafen like some issues problems come up time sometimes close me plus I got problem lo recruiting more participants do me plan lines so slow walk but sometimes me looking sa alright even el center sa close me pas recruit slowly. So I think good relationship one day me PNGIMR one day Alexishafen Health Center and more good So I think future time all collaborators or when the most studies all coming, all can work boom one day good partnership them staffs all can.
Yet me osem driver all project bin kisimi as a field driver. So miss I walk inside to one time. Now miss I walk inside lo community lo talk one time all man lo how lo IMR I walk inside lo desla IMR bin come inside lo here. Now me plus I also making all communities away where me play making work. You know what one community relationship all me stuff and me play yet me driver mi yet mi sawe go toto wantel man lo walk blimer. Na mi sa tokolem walk blimer osem na mi plasa walk wantem na mi plasa walk na olgeta lo community or lo place or man Mary or sawe lo mi pla lo walk inside. And first thing when mi pla go longen and mi pla go wantem sambla gutla onem lo mipla, ose mipla sa helping community, ose service go inside. Now look him handmark, lo IMRM go inside lo place na community. Work want them all community, yes, you got silence stuff. Plenty or community, you got some or thinking about we also talk about them or why you plus like sim gluteness I putting when and this law kindness I come up, that's all. Emol silence bol community tasor mi plus I talk one temol noga des la blut mi plus I kisi mi got walk blend lo let na mi plus I kare mi go lo let na osai luki lo hap na mi plus I talk one temol o sawe na sambla temosem before mi plus apply PTI or talk osem mi lo silence mi plus so mi plus kisi mol big plus loading mol community na goes look ground inside lo let. Now all been looking more planted something where me walk long end. Nelly, Hamamas, not of YSM, I'm me walk good walk inside one more community law. Not coast area na. We go lo mobile na come lo set. So now me walk one lo set and most of get a community sawe lo mitla so. Me walk one more inside na inoga one plus. Silence where say come lo ask him lo silence mitla lo kind talk and now inoga display stuff. Inside lo relationship lo mipla lo walk one time more and me good la. So on something only short long and mipla sa help him more.
To conclude, we are grateful to the Catholic Health Services and the staff at Alexishafen Health Center for the support and partnership in the success of all our clinical trials in the past and ongoing. We look forward to continued partnership and collaboration in improving health outcomes for our people locally, nationally, and on a global scale as well.
Thank you. So we have had from the Alexishafen team or the drug study team, one of the things to draw out from this is the community engagement, which is vital for community participation into these clinical trials. Gauging community support is very important, and having IMR work in these communities for such a long time, there is respect and understanding, and some of that you had through our presentations by our team. And that allows us to continue not only our clinical trials in these settings, but also our other research activities. So before we move on to the next segment, I want to just shout out to all our international partners, friends out there who joined us from Australia, from Vanuatu, Cambodia, USA, and China. A special mention to our friends from Australia, Deborah and Michael. Welcome. Thank you for joining us as always. Always appreciate your presence online with us. But also to mention Uni Melbourne, UNSW, Telethon Kids, Maddox Children's Hospital, DFAT from Hobart, Wollongong University, CSIRO, Menzies. Sorry, I'm just going to read all the names. You know who you are out there. DFAT, University of Sydney, James Cook University, and all the other friends out there. If we haven't mentioned, welcome. So now in our next segment, we will hear insights from the ethical aspects of clinical trials. As with any human participation, ethics considerations and assessments are always important steps to have in place and to comply with at all times. We will hear from Dr. Moses Laman, Reverend Graham Beitel, a member of the PNGIMR IRB, Ms. Eunice Jali, and our collaborator, Helen Minjala from Menzies. Thank you.
Clinical trials are a really important component of the type of research that we do at the PNG Institute of Medical Research. Obviously, in order for us to do clinical trials, we have to get appropriate ethics approvals, and this would require, for our case, this would require IRB approval, Institutional Review Board, as well as medical research advisory committee approvals. And once we receive all the approvals within country, if we have external collaborators that need approvals, we will also need to get those. And then we start trials. And of course, when we start trials, it depends on the nature of the trial and what type of trial we are doing. And if it is a drug trial, we obviously need data safety monitoring board or patient safety monitoring boards. And those are very important components of the trial to guarantee patient safety. And whenever we have severe adverse events or other forms of adverse events, we always report it to the institutional review boards and safety monitoring committees. So that's to ensure patient safety, and it's a very important component of trials.
My name is Reverend Graham Vital. I am a member of the Medical Research Institute IRB board of Papua New Guinea. I represent the Council of Churches in the country as a board member, and I have served for several years in this board. The role as an IRB member is very challenging, but it's very specific. Most important role of the IRB, from my perspective as a member, is the rights of the people in those who are taking part in the clinical trials. And so basically our emphasis is on the consent of those who are taking part in these clinical trials and how their rights are preserved. In this country, Papua New Guinea, as a developing nation, but also a multicultural society made out of 800 plus different languages and tribes, it is quite challenging when we want to assess clinical trials in various areas. Ethnically and culturally, not all are same. And so when we assess clinical trials and research taking place in various locations, we have to be considerate of that and how culture influences as well as provides not only the possibilities of a successful clinical trial, but the challenges that come out of these researches that affect the people's lives and their well-being. And so it has been a challenge, but it has been a journey of great learning and experience trying to understand our people, but also understand the value of science and research and how it contributes to the well-being of our people in this country as well as in the world. It has been a challenge also in trying to foster healthy development of research scientists in our country, which is an opportunity that comes with this research that takes place in the country when its protocols are sent and the research project begins. The opportunity that it provides for young Papua New Guineans, especially those involved in IMR, the opportunity to engage in collecting not only the information that supports the clinical trials and the research projects, but also provides the basis for their endeavor to accelerate and to gain their further academic qualifications in the area of sciences that they are involved in. And so it has been an opportunity for us as a member of this board to promote capacity building for our young Papua New Guinea scientists. And we thank the global scientific community for being a collaborative partner with our National Medical Institute and helping foster that relationship that enables the development of our young scientists for this country.
Hi everyone, I am Eunice Jelly. I am the clinical trial monitor for PAVE study. I will be talking about building clinical trial monitoring capacity development in PNGIMR. Clinical trial monitoring is purposely conducted to ensure the right and well-being of trial participants are protected. Accuracy of trial data ensures trial results can be trusted. Trial is conducted in accordance with the approved protocol where trial is run as it should be, and results are valid or reliable. So it increases the quality and efficiency of clinical trial, and it prevents problems or issues before they happen. The sponsor should determine the appropriate extent and nature of monitoring. The determination of the extent and nature of monitoring should be based on considerations such as the objective, purpose, design, complexity, blinding, size, and endpoints of the trial. There are two types of monitoring: on-site monitoring and remote monitoring. On on-site monitoring, we check consent is done correctly, real-time data checking to ensure accuracy of critical data. We observe trial is conducted in line with protocols. Support for randomization of trial products or interventions are carried out correctly. So trial participants' rights and well-being are protected. Trial staff are qualified, trained appropriately to conduct trial activities. In remote monitoring, we check data entry is accurate, and any issues with missing data or inaccurate data entry is promptly identified, and also documentation is correct. Monitors must be totally independent from the study or trial investigators and staff. Before the start of a trial, a formal monitoring plan should be developed. Monitors must be fully trained, particularly in GCP, as well as they must have a broad scientific background to enable monitoring of varied trial protocols. Monitors need to be very acquainted with the trial protocol and all procedures, as well as all steps to protect and secure well-being of trial participants. The monitor needs to follow the trial monitoring protocols established by the sponsor of the trial. Monitors should submit a written report to the sponsor within 5 to 7 days after the monitoring visit. This report includes on all agreed monitoring items, summarizing any significant deviations from the protocol, any suggested solutions, remedial actions, and recommendations for future compliance. And with that, thank you.
Hi everyone, thank you so much for joining today. To briefly introduce myself and my background in clinical research, I'm a registered community health nurse with a major in clinical research. I've been working in clinical research for the past 15 years, and I've had the privilege of holding diverse roles in clinical research management for several multi-site trials across sub-Saharan Africa, Asia Pacific, and the Amazonas. So my expertise spans in all phases of clinical trials, trial governance, risk-based monitoring, and the development of risk mitigation plans to ensure high-quality trial conduct. Today we'll mainly speak about support study, which is one of the studies that Menzies is collaborating with PNGIMR, and I've had the privilege of working with a very amazing team as the trial monitor. I mainly support the team remotely from here, but I've also managed to visit the site once towards the end of last year, and we plan to do a few more visits before the site study is completed. So before initiating the study, we developed a monitoring plan to sort of just help coordinate and effectively monitor the study to guarantee participant safety and data integrity. So the monitoring plan detailed the monitoring approaches to be used and the critical processes and critical data for the study. We also detailed the communication plan and how to handle any non-compliance. For quality assurance in the study, we've implemented several strategies. Before initiating the study, we conducted a virtual GCP training, and all the study team members were provided certificates at the end of the training. Then this was followed by a protocol training that was done by our study clinicians. It was an on-site training, very interactive and very practical, just to ensure protocol understanding and understanding of all study-specific procedures. We work with a very qualified and well-experienced team, but we also acknowledge that Support is quite a complex and very busy study dealing with vulnerable groups. So throughout the study, we are consistently sharing experiences, discussing solutions, and developing mitigation plans in order to complete the study with high quality data. In terms of monitoring, we've used several approaches to monitor the study. We initially had an on-site visit at the beginning of the study, then followed by my visit. And the main agenda of the visit was to meet the site team in person, review study procedures in all the participating clinics, identify any protocol adherence challenges, review documents, and provide refresher training. I was able to visit all the participating clinics, interacted with the team, and reviewed all the critical study processes. We also periodically review documents remotely by the help of the team scanning some of the source documents, reviewing safety reports, and other critical data of the study. Also work very closely with our data manager to review data entered into the database, identify any queries, support query resolution, to ensure high quality data. We also do central monitoring. So the study has multiple sites in Madang and all the data goes into one database, but each site has an independent identifier and we can compare site contribution independently just to identify any site-specific needs, such as clinic attendance. Then we are able to engage our community reporters for that region and discuss mitigation. Over the last couple of years, monitoring is shifting from the traditional on-site monitoring to a more risk-based approach, which is an innovative approach that focuses on identifying, assessing, and mitigating risks that could impact the quality and integrity of the study. So the initial steps is usually to do a risk assessment before the trial is initiated and then categorize the risks based on likelihood. In support trial, we did this before the study was initiated and had a meeting with the DSMB to discuss the potential risks and the threshold in the study, and it has been a continuous process throughout. So the DSMB has detailed review of the data we send quarterly, and we adhere to their recommendations. Based on the risks identified, we implemented a more focused approach to review the data collected, especially safety reports. We also work closely with community reporters who engage with the community to encourage early hospital antenatal clinics, follow-up visits, and hospital deliveries. We facilitate payment for hospital deliveries and provide incentives as well, just to encourage the moms to adhere to follow-up schedule and deliver in hospital. We developed data quality rules within REDCap database to help identify any queries, monitor data entry, and this has been very instrumental in ensuring we adhere to DSMB reporting timelines. Some of the challenges we've faced is slow data entry processes due to on and off internet challenges and the high workload to the data entry team and the clinical team as well, considering it's a very busy study. But through our collaborative efforts of all stakeholders in the study, from the clinical team, data entry, lab, and administration, it's been possible to mitigate most of the challenges we've come across during the study. All the efforts of the team are generally geared towards improving efficiency, enhancing data quality, increasing patient safety, and regulatory compliance. Finally, I would like to extend my deepest gratitude to the entire support team at PNGIMR. Your unwavering dedication and hard work has been very instrumental in the success of the trial. Thank you, everyone.
Thank you. Before I move on to the next segment, just to acknowledge we have 135 viewers online. Welcome and thank you for joining us. Also want to make a special mention to the Goroka partners joining our team in the auditorium. Partners from the Eastern Highlands Provincial Health Authority, Department of Livestock from NACIA, and the PNGIMR IRB members. Welcome. So our next segment will show the involvement of the labs in the clinical trials. Depending on the nature of the clinical trials, there are times when labs and field teams will need to work well together to ensure timely availability of results, to inform treatment options, next sampling, and all of that. And so now we will go to videos showing our lab presentations. Thank you.
My name is Joycelyn Sapura. I am a health extension officer at PNGIMR who was involved in the IMPROVE study. A total of 245 participants were enrolled into the study. Ascents were done from the labor ward, postnatal ward, and the antenatal mothers who were awaiting delivery in the ward. Mothers were approached and the study was explained to them briefly and verbal consent was obtained. On delivery, the neonates were screened for inclusion and exclusion criteria, and a written consent was obtained, and they were kept within the study for a duration of 6 months. Each participant received probiotics within 7 days consecutive, starting from the recruitment day, and had 13 visits in total over the 6 months. Activities involved routine vaccination at birth, 1 month, 2 months, 3 months, and 6 months of age. Health care was also given to the infants when they were within the 6 months. Sample collection was done on different time points. Breast milk at visit 1 to 7, rectal swabs and stool, if they pass stool at the time of visit, from visit 1, 7, 8, 9, 11, 12, and 13. Saliva was taken at visit 1, 7, 9, and 12. Nasopharyngeal swabs at visit 8, 9, and 12. And venous blood at visit 1, 7, 9, and 12.
Hi, welcome to Immunology Lab. We are the Immunology Lab under the vector-borne disease unit. We're based here in Madang under PNGIMR. We will go through the process of how we receive samples from projects or clinical trials under Immunology Lab.
From the field, we receive slide boxes with blood slides, placental membrane roll and placenta tissue, filter paper or dry blood spot, and whole blood and vaginal swab. These are case report forms. So we organize the samples in different visits. For example, this is the enrollment visit. So we organize them and we cross-check the slides, the DBS, and the placental tissue and membrane roll against the case report form, or CRF, to make sure that the date, IDs, and the visits are correct. Then we receive them in the logbook before we take it into the sample processing room too. The placenta tissue is used for placenta histology study. The dried blood spot, we use it for gametocide study, so it's sent to Melbourne to be processed. The vaginal swab is also sent to Melbourne for STI testing, and the whole bloods are separated into plasma and cell pellet. So this plasma and cell pellet. The plasma is for serology study, and the cell pellet is taken up to molecular level. After the slides are received and confirmed, we take them over to the microscopy lab to read for malaria parasites. receiving the samples, we take them into the sample centrifuge room to centrifuge and to separate into cell pellet, plasma, and so when we come, we put them in the whole blood. These tubes are already labeled, so we place them in the whole blood. And then we spin to separate. This is the centrifuge that we use. Place them in the holders. After 10 minutes, we take the sample out. Then we separate them into the plasma and cell pellet. So there's 4 plasma and 2 cell pellets. After separation is done, we take it to the freezer. For temporary storage, we put it in the -80 freezer. Later, we store them in the freezer storage boxes.
After we store the samples, we do the audit for all the samples for archiving and shipment.
Thank you. Welcome back. So before we move on to our next segment, just to acknowledge the East New Britain team, we are joined by our friends and colleagues and partners from the East New Britain Provincial Health Authority, Bennett Institute, who we work very closely with, St. John's Ambulance, Catholic Health Services, Gunapope, and then Napapar Health Center. Welcome, and thank you for making time to join our team in East New Britain. So from the clinical trials, what are then some of the benefits that result either to individuals as study participants, research staff, or to a wider community or to the health facilities where we conduct these clinical trials? We will hear from a few of our clinicians and scientists what some of these benefits may be either to them or to the health services. Thank you.
So here in Madang, we've got various health facilities where we conduct clinical trials. That would include a town clinic, Modilon, Jomba, Yagaon Rural Hospital, Alexishafen, Bugil Health Center, and other facilities depending on the type of clinical trial. Having that team over, especially at the rural outskirts facility, does boost the manpower of the clinical team there. And team were able to screen patients, co-manage with treatment, able to assist with lab assistance or doing hemoglobin for the very sick patient, quick reads for malaria, rapid diagnostic test of malaria, syphilis, and HIV. We're mainly doing a pregnancy trial, so our staff are trained to do ultrasound, and we have portable ultrasound at each of the health facilities when they are there. So they're able to do pregnancy dating for the moms. With the recent upskills, they're able to do growth scan and also able to identify and establish diagnosis of malpresentation at term, placenta previa, polyhydramnios, oligohydramnios, intrauterine growth restriction, and fetal death in utero. Having that team over is an advantage where we assist with doing complicated cases, managing very sick moms and baby, stabilize them, provide referral and transport to the provincial hospital for further treatment and care.
So I would say conducting research, in particular clinical trials in our setting, comes with a whole package of benefits. Benefits to us as the researchers and the IMR as an institution, but of course benefits also to the health facilities and the communities that partake in those studies. As an example, we often supplement medications and equipment at health facilities to enable good antenatal care, which is the basis of a clinical trial in pregnancy, and thereby, of course, supporting caregivers at the health centers with providing evidence-based care as per PNG guidelines. And this is something that's very, very important to us. So I think it comes with specific benefits, sometimes down to the individual participant. It comes with wider benefits because we're helping sometimes with equipment, and we're not only helping with clients that are ultimately enrolled into the study, but also assessing clients or patients that may not join the study or may not be eligible for the study but need our help. And thirdly, I would say that our staff members work alongside those health center or hospital nurses and provide their help in managing patients and managing emergencies and just helping out as and when required. And this is really a really great attitude because it shows that research is not being done for the purpose of research, but it's being done as part of healthcare. The other thing I would say, sometimes our on-call teams also help with transfer of patients or enable transfer of patients. As some of you may be aware, we operate in remote locations such as Mugil or Yagaum, and indeed sometimes we have very sick patients with malaria or a pregnancy complication or such as preeclampsia that need management, stabilizing management, and then transfer. And when able and when we are aware, our clinical teams try to encourage patients to seek care at Modelon, and we organize the referrals and occasionally assist with transfer of patients through alerting the local health center ambulances to give a hand. And I think that's often and quite frequently has made a difference. Speak from our experience and the experience that's being shared with me by our excellent clinicians, Dr. Alice Mengi and Dr. Paula Tessin, is that those studies have a huge reach in the community, in the sense that, of course, we're conducting community awareness so that we have the backing of the communities to conduct the study. And then when pregnant women attend the antenatal clinic for the first time, we give quite a comprehensive information session, providing all the details of what the trial would entail, but not only the trial, but also what the key components of antenatal care are, and what everyone should be receiving. And of course, not all of these women will ultimately be enrolled, because some of them might not be eligible, because they may be too far along in their pregnancy, for example. But certainly the message is out there that we are here, that we are doing these studies, that we are trying to do these studies at a very high quality level in terms of clinical care provision, and that we are enabling and supporting women even after birth with baby bundles and good aftercare, so that ultimately they have a really good pregnancy experience and hopefully a better outcome.
Hello, me I'm Janet Kuleba. Me want to community health worker. Me involved for 2 trial. One and one-time trial na support trial. One time me been training in 2017. Na me train also USS technician. Na me say making pregnancy dating law one-time start trial. So now me start one-time support. Me kisi more skills again law making USS ground scale. Na me say help me bell mama. So I miss a scan gonna miss a looking at some condition where I'm not right. Like baby and leg campus, baby sleep crossway, one plant inject lo bilum lo baby, or bilum keke lo baby and passing way blow rod blow beginning lo come out, or baby and die inject lo bilum keke bilum lo baby, or bilum keke lo baby and no stop all right. And Mr. Lupin and Mr. Stalin got a big blouse, doctor can help me. Now, Mr. Lupin was a more mama's there, like in more like Savile or baby boy or girl, and Mr. Lupin and Mr. Tokimolos and baby boy start against Mr. Tokimon. Now, Lautu and me one blood visiting counselor too, so Mr. Elpimolo making one blood testing before, but now I'm suffered. Helping me have skills lo me lo visit site me been gonna is in triple testing now or making land, so me plus helping lo clinic normal clinic sites. I'm on visiting as on system me plus helping mo checking the standard model visit site HIV positive me plus salim go long nurses talks about positive negative me plus sinna pati lo study na me plus lo go timon go ina on kale. Now I must make a big plamamas long PNGIMR, 9 jet lo 2 trial, one time support and must make this in more experience, more skills. Na me help plant your mama in jet lo trial blow me plant, na country blow me plant, yeah. So big plamamas must me gaining more skills, na more experience.
My exposure to clinical trial in PNGIMR was back in 2011 as a third year medical student, where I did electives and Alexishafen and Mogil, where the team were working on the clinical trial of artemisinin neptoquine and artemether-lumefantrine treatment of the uncomplicated malaria and PNG children. And I did my elective project on the prognostic value of hemopoietic indices of PNG children with malaria, which I successfully completed. And then I returned in October 2016 as the deputy trial coordinator to the one-time trial. Working with one-time trial, I was as part of local capacity building, I was able to develop a sub-study within the trial to do my master's project, which I successfully completed, and it was funded by R4D grant through the Swiss National Foundation through one-time trial. After that one-time trial ended, I transitioned into support trial as the trial coordinator, co-managing the trial with my colleague Dr. Tesine. That trial will be part of my PhD study, and through the trial I was able to secure a small grant through Development Research Award, and that will also contribute to my PhD studies. Overall, engaging in clinical trial had advanced my has played an important part of my career development. It also provides a pathway to excel through a higher education, having advantage to build self-study within clinical trial, and having PIs and co-PIs as supervisor. We were also able to do training and upskilling of our staff, enable me to able to successfully apply for small grants, and involving in clinical trial improves our policy and treatment guidelines, and it builds the basis of new clinical trial or research opportunity.
So to conclude this session on clinical trials, as you have heard from our clinicians, I myself is a medical officer or a doctor in medicine, and now I am a researcher. Clinical research and research in general forms the foundation. So shouting out to all my colleagues, doctors out there, you can see Dr. Alice Emcee is one of our young ones going into becoming a PhD holder, not for the PhD holder, but someone building that capacity amongst the healthcare workforce to lead research in our country. In the next segment, we will hear from Professor Vallely and Associate Professor Moore about the pathways to impact. And after that, we will hear from Dr. Laman, Dr. Anga, Dr. Neuendorf, and Dr. Emcee on what is next in terms of clinical trials in PNGIMR. Thank you.
I'm incredibly proud of the interventions research and our clinical trials that we've conducted together at the Papua New Guinea Institute of Medical Research. And I think one of the great strengths of the Institute, from my perspective, has been our ability to really capture the issues and the priorities and some of the problems really that our stakeholders and partners, and particularly communities, have raised and have come to us with and asked us, how can we address these problems? How can we work together to tackle these key issues to improve public health, to improve the health of the people of Papua New Guinea? And I think for me, one of our great examples in one key area where I work in cervical cancer and prevention and cervical screening has been the incredible collaboration and partnership between the Institute, national and provincial health authorities, and the society, the PNG Society for Obstetrics and Gynecology. The society has been really incredible in its leadership and its vision. It first came to us in 2010, really asking how can we work together to identify a suitable screening algorithm for women in Papua New Guinea for cervical screening.
It's my understanding that changing therapeutic guidelines for any treatment involves a rigorous and evidence-based process that relies on a diverse group of stakeholders to achieve the desired outcome. The revision of the treatment guidelines can only occur through the generation of robust data within the focus population groups in which the evidence of need for change has been identified. So here we can actually conduct our research trial. And upon completion of the trial, it's then crucial that we ensure the research outcomes are effectively disseminated. Should new data support the need for change, then findings will be shared with those stakeholders who hold positions on therapeutic guideline working groups. Now, within these groups, the membership includes a diverse team of experts. We have clinicians, researchers, and consumers. And it's their task to critically appraise all available evidence and update treatment recommendations based on new evidence that's been generated or changing clinical practices. And it's in this process of ongoing monitoring and evaluation that ensures that national treatment guidelines remain relevant and effective for Papua New Guineans. An example of the drug study team activities where PNG treatment guidelines has been changed is the first standard treatment trial, which was conducted between 2005 and 2007 at the Alexishafen Health Centre. So here the trial recruited children with uncomplicated malaria who were randomised to receive either national standard treatment, which at the time was chloroquine, sulfadoxine, pyrimethamine, or randomised to one of 3 artemisinin combination therapy groups. The results obtained in this study clearly demonstrated the superiority of ACT regimens to chloroquine SP, specifically artemethyl-lumefantrine and dihydroartemisinin piperacin. And this contributed to the data that was presented to the PNG National Department of Health, which resulted in the eventual change of national treatment policy for uncomplicated malaria.
For the future of clinical trials in Papua New Guinea, we want to be able to build capacity within the institute so that we could conduct trials on new tools that are becoming available, not only drug trials and drug regimen trials and new methodologies, but also vaccines, for example. IMR used to be a powerhouse in terms of medical research into new vaccines, for example, the pneumococcal vaccines that have changed the standard treatment guidelines for vaccines. Childhood vaccinations in Papua New Guinea were trialed in Papua New Guinea. Some of the first malaria vaccines were trialed in Maprik in East Sepik province. And in much more recent years, we are currently actually planning to do vaccine trials on the R21mm vaccine if we have opportunity to receive funding for this program of work. The RTSS vaccine is already approved, WHO approved for trial in children, for use in children in African settings. That's a falciparum vaccine. And in our setting, we don't know how well it would work in our setting where you have co-endemicity with multiple Plasmodium species. And so this is one of the things on our radar for the future. And of course, the tools, if we have new tools coming on board or point of care testing in any diseases, those are capacities that we have within the IMR to conduct trials in ensuring these new tools can be used by our health system in Papua New Guinea.
I'm of course biased. I'm very interested in things related to pregnancy and pregnancy outcomes, and of course also infant outcomes, because the journey of an infant starts right at the time of conception, and some would argue even before conception. So I think the future really lies perhaps in clinical trials looking at optimizing women's health before they fall pregnant, so that they are entering a pregnancy in the strongest, best possible health. And that includes entering the pregnancy without malaria, for example, or other health problems in a good nutritional state, and then guiding that pregnancy towards a really good outcome. And of course, there are many barriers that we have to overcome, not just from an implementation perspective, but also from an access perspective. In other words, we can conduct many trials showing, good antenatal care has good outcomes, or IPTP, preventative treatment in pregnancy, has good outcomes. But in the end, we have to make sure that those treatments reach the target population, the population in need. And that is something that, of course, needs to be aligned with any clinical trial that we are trying to conduct. It's also very exciting to have those new labs being built, and I think that is a wonderful key step forward. And when we soon have those facilities, then I think we can take the research from the clinic to the bench side directly in Madang, and that means that we can conduct clinical trials and do the primary analysis of the various outcomes that the trial would measure. But then we also have the ability to conduct hypothesis-generating research in Madang, meaning that we can develop new approaches, new treatments, and take those forwards in subsequent trials. I hope that, and I think IMR is already part of a bigger network of low to middle income country research facilities that work together to address problems that are similar across some of those settings and shared. And I think sharing that knowledge between researchers that are tackling in their own countries similar health problems is really, really important, and that will generate a lot of new and good and pragmatic and meaningful ideas.
One of the things that I wanted to talk to you about today is how we will be integrating qualitative research a little bit more into our clinical trials in the future. Clinical trials predominantly about testing and assessment, and most of the indicators are quantifiable units. The addition of qualitative research methods into clinical trials is really important to what we do here in Papua New Guinea in regard to people's acceptability of certain medicines or interventions or programs. Because, you know, at the end of the day, it comes down to how people accept the information that's being given to them and understand it and then integrate it into their ways of doing and being. And that's very important to what we do as social scientists here at the PNGIMR. I think one of the most interesting things about what we do, and especially in complementing the clinical aspects of research, is that we not only look at things from a community perspective, we also look at things from the human perspective in our key stakeholders. So from national department levels to provincial levels to district levels to healthcare workers, to doctors and nurses who are administering new interventions, new medicines. Human elements of all parts of the health system are really important to creating a full picture of how we best then provide service for our people. And that's where qualitative research, social science research particularly, comes into play. It helps us to broaden our understanding of all of the human elements of what makes up our health system. And that's the strength of what it can offer to things like clinical trials in the future.
Relating to future of clinical trials at PNGIMR, with our current team evolving with increasing number of staff capacity, we have the potential to have a larger clinical trial unit where we can test or try products from manufacturer. However, for IMR to absorbing large number of staff, finance may be a constraint. Thus, if IMR to adapt such idea, then we may start with small products or trials that are more relevant to our settings to improve policy guidelines and patient treatment and care to improve better health and livelihood for our people.
Thank you, and we've come to the conclusion of our clinical trial session. Thank you all for staying with us, and thank you to all the presentations thus far. We hope you all have enjoyed our clinical trial session and learned something about clinical trials, but also understanding the intense work involving many aspects of research to be working well together in terms of community engagements, clinical and health facility support, and always that everything we do always must ensure we follow ethical standards of conducting clinical trials with respecting and protecting our study participants' rights and safety always. Now, with that, I thank you all again, and we will move on to our lunch break. Thank you all. Hi again, everyone. Welcome back, and I hope you had something to eat and you are more relaxed. Thank you for joining us again for the last few hours, hopefully 1 or 2 hours before we wrap this up. So after this, we will start off with a spotlight sessions showcasing some of the work of the young PNGIMR staff. And so we have staff who have recently completed PhD and are currently undertaking their PhD. So starting off, our first spotlight will be presented by our own, very own Dr. Nelly Saweri-Kanasa, who completed her PhD this year. She's one of our first health economists, and we are so proud of her. And today she will share some of her findings from her PhD. Over to you, Nelly. Looking forward to hearing your presentation. Thank you.
Thank you, Maria. So after hearing a cascade of information today about clinical trials, it beckons the question, which way, big man? So today I'd like to introduce the idea of implementation frameworks in Papua New Guinea. Slide. We'll start today off by introducing implementation frameworks in the frame of implementation science and research translation, then go to introduce one such framework, and then populate the framework and take some notes about which way forward. Slide. Slide. Implementation and scale-up of public health interventions is challenging, especially in resource-constrained settings. And the link between research and clinical practice is likened to a black box where you don't necessarily know what's going on in the box or the parts that are connected in the box, but at the end of it, something comes out and we scale up some sort of intervention. And this is where implementation science can be helpful. Implementation science, and sometimes partnered with research translation, describes an iterative process to improve population health by scaling up research into practice. And implementation frameworks are that formalized bridge between research and clinical practice. There are so many implementation frameworks out there. Sorry, excuse me. There are so many implementation frameworks out there, one not better than the other. But what's important about the frameworks is that they are comprehensive, because scalability not only depends on efficacy or effectiveness, there are many other determinants, including economic and equity considerations. So let's start by shedding light on this black box and introduce a framework. Slide. So this is one such tool. This is the Intervention Scalability Assessment Tool, or the ISAT tool. It's an overarching framework or a checklist that assists decision makers and researchers assess whether or not an intervention is scalable. The model was developed from the review of 15 frameworks, checklists, guides, and tools, and they pinpointed 10 of the most important factors for scaling up. What's important about the ISAT is that it synthesizes all existing evidence in the model, or the system, I should say. It identifies the gaps, and in order to implement, it identifies gaps, and it tells us where we need to generate more information in order to make a decision about scale up. The ISAT is comprised of 3 parts, A, B, and C. Part A is the foundation. B is the information which we need to explore in order to assess whether or not we are to scale up. And part C is the assessment of scalability. So this already shines a bit of light on that black box. Slide. So let's look at populating the model in terms of workable ideas. So here we've shaded in green, the green components of the ISAT, which is information that we have already. And if we look, for instance, in context of interventions in antenatal care to improve the utilization of antenatal care and reduce to reduce the risks of adverse birth outcomes with essentially having to improve maternal mortality. We see that we know the problem. There are many interventions, and we have political support in order to drive reducing maternal mortality. There are several interventions which we know are effective, and we have field tested several in Papua New Guinea, and we have adapted many tools in order to address these issues. However, what we know little about is the cost effectiveness, or even equity. We need to then take scope and take a step back and say, but what about the fundamentals of antenatal care in Papua New Guinea? Because we still don't have that. Slide. So now to turn our attention from what we don't know to what we do, from what we do know to what we don't know, we've now shifted the light green boxes, which are now shaded out to white, and we focus on what we don't know. And that's the focus of this presentation. The light green boxes here are the domains which we need to produce evidence for, and the darker green boxes are the types of analyses which can fall under these domains. Slide. So let's jump into some of this information. So before we investigate economic evaluations of interventions, we need to know baseline costs. We need to know where to start. So that's this. So for us, it's calculating the cost of routine antenatal care in Papua New Guinea. We've calculated routine antenatal costs by recurrent costs and capital costs, and determined that staff costs are the largest driver of routine antenatal care costs, which is unsurprising. And we've produced then the cost of routine antenatal care per year, which is 16.9 million kina, 6.9 million international dollars. This is a large number. However, this is only 1% of the national health sector budget. Slide. So now when we talk about reach, we look at what would potentially cost us if we were to scale up to all pregnant women receiving antenatal care in Papua New Guinea. And so we look at using a linear scale up of the annual health system cost in order to show that costs would increase by over 200%, approximately 229%, from 16.9 million kina to 55.2 million kina annually. And this is a large number, but this is still just a drop in the ocean in terms of the health sector budget. Slide. Another important component of reach is looking at equity. We see that it costs a lot of money to deliver care, but are women accessing care? When we look at our population, we can see that our population is largely impoverished. And because of this, we want to see if poverty is actually a driver of antenatal care attendance. We find, though, unfortunately, that there is inequity in healthcare. So the women who have the greatest need, the poor proportion of the population, actually don't access care that relatively to the more wealthier part of the population. So when we look at the drivers of care, we actually find that poverty is not a driver of care, because cash on hand is not a driver of care. And that means that we have to do something else in order to encourage women to access care. And so we have to look at demand incentives in order to encourage women to go to antenatal care clinic. Slide. So now we're jumping again, and we're looking at the supply side. We're looking at delivery setting and workforce. And here we talk about service availability, and which is the physical presence of services measured across 3 indicators: infrastructure, workforce, and antenatal care utilization. And an average score is produced from these indicators, and it tells us whether or not a province has enough open health facilities, has enough health workers, and women are accessing care. We see on average, service availability is 32%, with a minimum score of 20% and a maximum score of 66%. So service availability is low. And what's pushing down the delivery of service is the workforce and poor access or poor antenatal care utilization. So something needs to be pushed into improving underutilization here. Slide. Now moving from service availability to health facility readiness, which is the capacity to provide antenatal care across Papua New Guinea. And this is calculated from a equally weighted score of 28 indicators. And it tells us if a health facility is able to effectively provide services. So a score of 100% here in this graph indicates that all health facilities are able to provide the service there today. We see that on average, urban health facilities perform better than rural health facilities, and we see an average readiness score of about 50%, so which is okay, but there's still ways to go. There are quite a number of important gaps here, which include sanitation and electricity. And there's also poor availability of diagnostics. These need to be addressed. Slide. Finally, we look at sustainability. Now, sustainability looks at affordability, and that for us is largely a budget impact analysis. So all budget impact analyses have shown us here is that if we were to scale up to the universal coverage of 4 antenatal clinic visits or even 8 antenatal clinic visits, we would increase the cost of antenatal care by over 200%, and for 8 antenatal clinic visits over 500%. But these are still just 1% of the total health sector budget. Okay, so let's round off here. Sorry, slide. So let's round off. I think what this presentation shows is that there are a lot of different little parts that make scalability difficult and challenging, but there's also different parts that we need to invest in and we need to look at more. There's a need to collate existing evidence. There's also a need to utilize resources effectively and enable us to identify the gaps that we need to invest in order to generate evidence to drive implementation. Implementation frameworks are in their infancy in the Pacific, and I think we should potentially look at them as a useful tool to guide various sorts of evidence needed to scale up interventions. Slide. These are the references that I used for this presentation. Thank you so much for your attention.
Yes, thank you, Nelly, for a wonderful presentation. We will now move on to our next presenter, Diana Timbi. She has recently started her PhD, and today she will be talking to us about developing a risk stratification for targeting malaria interventions and accelerate towards elimination in PNG.
Hi, my name is Diana, and I will be presenting to you an overview of my PhD project. My PhD project is part of a main study that is looking at developing and validating conceptual framework for malaria stratification. Globally, malaria has stalled over the last 10 years as seen on the graph. In Papua New Guinea, there was a resurgence in malaria in 2014, which coincided with decreased bioefficacy of long-lasting insecticide nets, drug stockouts, and an overall reduced in the investment in malaria control. Factors such as weak health system, human behavior, vector behavior, and environment and climate might contribute to the malaria transmission seen in Papua New Guinea. Therefore, the National Malaria Control Program in Papua New Guinea has to move from the blanket coverage of the same interventions to more tailored sub-national intervention approaches to effectively use limited resources and interventions and maximize their impact. So why do malaria stratification in PNG? PNG has a lot of local data and contextual information that can be used to determine an approximate mix of interventions and delivery strategies for optimum impact on transmission and burden of disease. In order to do that, we have to know the driving factors of malaria transmission, the heterogeneity of malaria transmission, and prevalence, and at which administration level to stratify best. The overall objective of my PhD project is to contribute to the development of a multidimensional stratification of malaria in PNG as a basis for implementing effective targeted malaria control interventions at sub-national level. The specific objectives are firstly to assess risk factors associated with malaria infection in the national malaria indicator surveys conducted in Papua New Guinea between 2016 to 2023. Secondly, to investigate the relationship of the routine indicators with population survey prevalence from malaria indicator surveys. And thirdly, to stratify malaria risk using routinely collected data from health facilities and its covariates. For this PhD project, I will be using community prevalence data from malaria indicator surveys, malaria test positivity rate, and annual parasite incidence from outpatient health facilities collected through ENHIS, and also environment and climate data from GIS and remote sensing. For objective 1, I will use multi-level logistic regression to assess association of risk factors for malaria infection. For objective 2, I will use correlation analysis to quantify strength of relationship between a routine and population survey indicator. I will use bland Altman analysis to test their agreement. For objective 3, parasite prevalence, test positivity rate, and annual parasite incidence will be calculated at the district level. Stratification of malaria indicators will be guided by work done by our colleagues in Tanzania. Some of the expected outcomes are risk factors for malaria infection will be documented for PNG, and also a risk map will be developed at the sub-national level. I have come to the conclusion of my presentation, and I would like to take this time and acknowledge the contributions from the following partners. I would like to thank the participants of the 6 malaria indicator surveys, Papua New Guinea Institute of Medical Research, National Malaria Control Program in PNG, the Rotarians Against Malaria in PNG, the Swiss Tropical and Public Health Institute, and the University of Basel. Thank you, True.
Thank you, Nelly and Diana, for wonderful presentations. So now our next session will be about STRIVE program, and you will hear all about it soon. But this work followed a strong partnership approach under the leadership of the National Malaria Control Program, which was led by late Mr. Makita, late Mr. Leo Makita until his passing this year. Before we show this work, we take this time to acknowledge and remember late Mr. Makita, his leadership, guidance, and support in not only STRIVE, but all of our PNGIMR vector-borne diseases research. He was our strong supporter, enabler, but a friend and a mentor. We will hear also from our friends and colleagues who together we worked with late Mr. Makita in our vector-borne diseases research.
Hello everyone. I'm also very honored to say a few words for our late Mr. Leo Makita within the framework of this virtual symposium. I think with Leo, PNG lost one of its longest serving malaria control specialists. Leo Makita was an entomologist by training, and in fact he signed all of his emails with the phrase, "Mozzie warrior, zap them all." Reading this always made me smile, but also gave me some hope, as it indicated a good sense of humor in the face of a very challenging malaria control problem in the country. Leo's leadership of the malaria control program reflected a strong entomology expertise with a great emphasis on vector control. And by doing so, the program made significant progress towards reducing malaria cases in the country. Leo's tireless work and support for so many PNGIMR entomology projects deserve all of our gratitude and will not easily be forgot.
Thanks very much for the opportunity to pay tribute to and acknowledge the immense contributions of the late Mr. Leo Makita. Leo dedicated his career to making meaningful contributions to strengthen malaria surveillance and control in Papua New Guinea, and in particular to strengthening the links between research and program implementation. His leadership and contributions to STRIVE PNG were essential to the impact the program has had and is continuing to have in strengthening surveillance and response to vector-borne diseases in the country. His willingness to play a leading role in this and many other vector-borne disease research programs to really contribute to embed research staff within his program and program staff within the partnership have instilled this way of working in the next generation. Leo really was such a champion of the partnership way of working that has guided us in all of our work over the last 10 to 15 years, and his legacy will be the continued impact of that in advancing malaria control in the country. But for so many of us, Leo was also much more than a colleague. He was a mentor, a friend, and a fierce supporter. He was always such a generous colleague too, always willing to share insights from his decades of experience in navigating the complexities of the PNG health system and malaria control in the region. Leo, you're so deeply missed, but the lasting impact you've had on the program and on the careers of so many will continue to guide us and maximise the impact we can achieve together. Thank you.
Thank you all for joining us in remembering the leadership and guidance of late Mr. Makita. Now we will move on to our next session, STRIVE, and I am honored to introduce Professor Leanne Robinson, who's a friend, who's my supervisor and a close IMR family member who's been with us in Madang for such a long time, and now she's back in Melbourne. She will introduce the STRIVE program, and then we will move on from there. Thank you, Leanne.
Thanks so much, Maria and Willie and everyone. So pleased to be able to join you. What a wonderful showcase of PNGIMR's work, leadership, emerging talent and impact. Just really well done to everyone. This is such a fabulous event every year that I really look forward to. So I'm so delighted to introduce the next session on STRIVE, a program that, so many of us and particularly the late Mr. Makita were so proud of. It's a vector-borne disease surveillance strengthening program that was built through an explicit partnership-based approach under the leadership and according to the priorities of the National Vector-Borne Disease and Malaria Control Program, as well as the provincial health authorities in our 8 priority provinces. It was designed to address priority knowledge gaps, improve access to and use of data to guide program decision-making, while simultaneously strengthening the health and vector surveillance and control workforce. So today you're going to hear some great insights from Annie and the team and reflections about the program from the leadership and the facility teams in one of our provinces. But I wanted to acknowledge the immense contributions that are made by these teams across all 8 provinces at community, facility and at PHA level, the contributions and collaborations of program, technical and research teams at the national level across multiple organisations, and the support that's provided through numerous technical partners in Australia. It's only through people's trust and their generosity to contribute their time and effort that this program has been able to reimagine how we can achieve a strengthened program of vector-borne disease surveillance and control in PNG and the region. So let's hear more from the team themselves.
Conducting implementation research in PNG requires innovative approaches to navigate the complexity of the setting. STRIVE, an implementation research that focuses on molecular, vector, and febrile surveillance, started in 2018 and utilizes a partnership-based approach that is contributing to support the efforts of vector-borne disease surveillance in PNG. The STRIVE Sentinel surveillance sites were strategically selected to address the progressing need for surveillance, rapid diagnosis, and tracking of emerging infectious diseases. These sites include Barrow in West Sepik, Montfort in Kiunga, Hohola in Port Moresby, Boimo in Morobe, Karamoy in Chimbu, Sausi in Madang, Lamekot in New Island, and Escape in Milne Bay. In this video, we capture a brief insight to the different surveillance components under STRIVE. We highlight some challenges of conducting implementation research in a low-resource setting and feature some success stories.
In the malaria program, we have several diagnostic tools that we use to diagnose malaria. One is microscopy, and microscopy is the gold standard. And RDT, we introduced RDT in 2011 after we changed our treatment protocol in 2009. And every health facilities in the country, they are equipped with RDTs. We make sure that our RDTs are at every facilities, that's including the hospitals and right down to the hospital, to the health center level, and also to aid posts. And also we have introduced the new program called HMM program, and RDTs are also at the HMM sites. The volunteers, they use RDTs to do the diagnosis if someone comes with fever. So we don't have any other, like for malaria and vector-borne, the mosquitoes that gives some mosquitoes, all the mosquitoes, they spread all kinds of diseases. And we malaria program only concentrate on the on the malaria part, which is the RDT and microscopy we're doing the diagnosis. But we don't have a test for other diseases that also are caused by mosquitoes, like Zika virus and chikungunya and yellow fever and so on. So at the department, we don't have the RDTs for those specific diseases that are spread by mosquitoes. And so the work that our partners doing, like for example PNGIMR is doing some work on the sentinel sites, they're also going beyond into to see, like after they do the RDTs, and if the RDTs are negative, then they look for other causes. And they are now checking on this Zika virus and chikungunya and all other diseases, and which is a good thing they're doing, because at the department we don't have this information coming from the facility level right up to the NHIS level, because our NHIS doesn't capture all those diseases. Those Zika virus and chikungunya and so they are reported under the surveillance unit. And to date, the program doesn't have the baseline information for those diseases. And so, what IMR is doing, it's a good work that they're doing, because we need to really know the baseline information. We need to know the real prevalence of those diseases, and also the RDTs are not available for Zika virus and for dengue. We do have some RDTs, but it's more centered in NCD and few parts of PNG. They basing on the request that is sent in by the professors. And so we need to really know the prevalence of Zika virus, yellow fever, and virus and all those, because to date we don't have the baseline information, and we don't know the true picture of those diseases. And these diseases are also spread by mosquito, and they also cause fever. And at the facility level, when health workers do the RDT, and if they find out that if the test is negative, they sometimes can continue to give antimalarials. And like the work that IMR is doing is also going to be a benefit for the program, because we don't have those information on other diseases that are also spread by mosquito.
The program is very honored and grateful to have Strive PNG under the PNGIMR that's supporting us in some of the activities that we don't have enough capacity to implement at the provincial level, and like generating data for the program. So we have this mechanism in place by these 8 sentinel sites that send in monthly data of the RDT kits that they are performing at those sites. They're sending the invalid results to the program. So we are grateful to have this mechanism in place to monitor this performance of the RDT at the sites. So because we had reports from the facilities around the country that there are some RDT kits that's giving these invalids. So this mechanism that was put in place is to support the program in generating this kind of data. So we have this data coming in every month, and we monitor the performance of these RDTs. This mechanism gives the program justification on which kind of RDTs that are performing out there. So we see that these ones is giving a lot of invalids, and these ones are really performing well. So when it comes to procuring these RDT test kits, we can have this data in place to justify procurement. And also, like the health workers, like out in the facilities, they have a lot of work to do. They see a lot of patients, and those most severe fever cases, they have to do RDT to confirm whether it's malaria. So like if you have a lot of kits and they're like performing one test on this kit, and then next month there's a different kit again, so you see it's a lot of confusion among the workers. So we have to have this information in place, so when we are procuring and distributing the RDT kits throughout the country, we have a standard RDT.
Right now we have about 6 different RDTs circulating within the country. that is costly with the data coming in for invalid. We can recommend by using this one to procure 2 to 3. Through this research through PNGIMR, it helps the program to decide which additives we can cut down, which will be cost effective.
It's a new sort of a thing that has been around, but it's new in the PHA setting. And for Milne PHA, we are pleased to have a vector control officer alone. So for us, it's a good thing moving forward since vector is new, and to be involved with the other PHAs is a good stepping stone to learn from them, and also for them to learn from us.
We do have a problem with vector control activities in the province. You can see the surge in malaria cases. So we value vector control partnership, and we are thankful to the IMR for the opportunity to be part of this with other PHAs. We value Strive PNG partnership. Especially myself, I do value because of constant communication and updates I received from them. Consistent communication from time to time. We value feedback from partners, and which Strive PNG is doing extremely very well with the feedback. They collect data and they do inform us, and we need those data for decision making. It will help us to guide our interventions in our local context. And I'm aspiring to continue to the dialogue with Strive PNG, not only the Sentinel site, but with other vector control activities like what we are doing now with the development of microplan, Strive PNG. So they're not coming only one agenda, but they are coming in the almost like package type. We are doing collecting data at the same time proposing some interventions to be used.
One of the achievements that I've seen is the number of cases that we've collected every day caused the number to increase. Like previously, what I've seen was that the number of cases seen in escapes Sentinel site wasn't high. And after when I came inside, and then there were some changes, and also the project was like partnered with PHA. Okay, the environmental health team at the PHA has the connection to Tupaya, so they monitor our performance too. So when they saw that the number of cases have increased, they came. And we had to go around and do a survey kind of thing with the councillor, and they stepped in to run a project here where they will be coming around and spraying houses.
The Strive PNG project partnered with Tupaya in early 2019. Beyond Essential Systems, who are responsible for the Tupaya platform, is a DFAT Centre for Health Security supported partner, and they provide end-to-end healthcare software and solutions for all settings. Their Tupaya platform aims to aggregate and visualize data from multiple sources with the aim of improving medicine availability, mapping and detecting disease outbreaks, responding to disasters, and strengthening service provision in the Indo-Pacific region. Strive PNG aims to establish and develop a robust, real-time and actionable vector-borne disease surveillance system, which looks to integrate febrile illness case data with molecular diagnostics, local entomological data, and supply chain data. And for that reason, for that need across the capacity to integrate multiple different data sources, the Strive PNG project made the decision to partner with Tupaya as our data integration and visualization platform.
While working under the project, there's some such challenges that I faced. Basically, ESCAPE is a center line for all referral centers. So one of the challenges that I face here as a malaria officer and assistant to Lila is that the number of patients that come in different seasons. Okay, sometimes we do not collect patients according to what we expect, because sometimes when they come in, Like there are seasons where patients come in mostly with malaria cases, and there are sometimes some seasons where they come in with less number of cases, especially in terms of malaria. Okay, so we say maybe January, February, we received a lot of cases with malaria. March, April, a little bit lesser than what we received. So the challenge here is maybe due to the weather pattern that's causing them to flood in with these cases. Yes, definitely the community is, especially escape community, is really benefiting from this project due to the fact that we don't only treat and send them home, but we also go out and visit their places and see what are the main factors that are causing them to mainly get infected with this disease, malaria. So yes, it is really benefiting the people of escape especially. From what we are actually doing today will show us what will we do, what we will actually do in the near future. So for example, like currently, because escape is not a waterlogged area, the mosquito larva sites usually land only at the water-based areas. Okay, so looking at that, we can be able to, in the near future, we can be able to determine the benefit of the people and looking at areas where mostly the mosquito larvas set. So we'll create that understanding between them and how they get infected with the disease.
Yes, we carry on with our project here. Our friends are very interested in, like I said, it's not something that we all learned in school. It's something new here. So as we collect blood samples, so we send data, so our friends are very much interested in it. So every day they have a lot of questions to ask, and we will always try our best to answer them as much as we can.
But research is important. There are many questions that we ask, and we need to answer those questions. And there are also many things that we don't know. So in the process of addressing the hypothesis, we may find some things that never crossed our mind. Yeah. And then we might find it either useful or harmful. Yeah. So research is very crucial. So for us within MBPHA, we encourage operational research.
There needs to be more operational research done. Like we are saying, okay, there's malaria happening here, but we need to know what's the cause of it so we can come up with interventions to sort of resolve the situation. So those situation analysis will only be uncovered when you have more operational research to inform the decision making, and then you can strategize plans on what to implement.
Resources, we are limited to it. Then partners to come in to do those activities for us.
We have different players in health business, and if those players are not engaged, we will struggle with health. So health it's a partnership, and so you can see that our motto in health is that health is everybody's business. Yeah. And so partnership is very important, regardless at the national level, at the provincial level, at the district level, at the LRG level, and at the ward level. Health partnership is important. Whether it be communication, transport, capacity building, we have to do that together. Yeah. And so in this case, it's IMR. IMR is a very important partner in health delivery. So IMR is concentrated in research. And if we can work together with IMR, there are many things that we know, but there are a lot of things that we don't know. So research will lead us to that. So the questions that we ask, the research can help us identify the solutions, the answers, and it will continue to allow us to address the issues before us, the questions that we continue to ask.
We have a lot of data, data sources or database around. We don't have surveillance that's, always there to tell us that something is about to happen. So moving forward, it would be nice for locally instead of all this data going to one place. Most times you have the outbreak that happens and then the data sort of tells you later. So we are not, responding to what's at hand. So going forward, if some sort of arrangement can happen where we get, data on the spot to react.
We value Strive PNG partnership. Especially myself, I do value because of constant communication and updates I received from them.
With the Strive team, we have good communication coming in, not just from the visits, but with updates with Tupaya and that sort of thing. So it's a positive thing moving forward.
So before we could start visualizing our data in Tupaya, we had to go about establishing our Sentinel site surveillance. And we did this by engaging, planning, testing, implementing, and now supporting our PHA and health facility partners to collect data and collect samples to meet the needs of the surveillance system. So we started with engaging with partners in early 2019, and this continued through until 2021 with some breaks due to the pandemic. And what we did is we went out and worked with the provincial health authorities and the health facility partners to discuss which facility would be most suitable and how we'd look about conducting surveillance in that setting.
Communicating with PHA is, I'd say it's very easy for me because I was once working with provincial hospital, so communication with them, it's not that very difficult for me because most of them know me and I know them as well, so communication towards them is not that very difficult for me.
When we have visitors come, is they come and they just, lay out what they want to get from us and they go without any feedback. With Strive, we've had experiences of, even having debriefs after their follow-ups, which is a good thing for us because whilst it's good for you to come into the province and do what you need to do, it's also important that we see some feedback before you go. And we've had other programs that don't send any, feedback at all. So we support the Sentinel Center very much. You'll realize and from experience that it was a good, sort of partnership arrangement for Strive and IMR to come in and sort of liaise directly with the PHA to get someone we know or someone with that caliber to be there.
One thing I like about Strive team, we communicate well here with our team in Escape and also the health facility at PHA and myself. It's important for us to get involved in the meeting because we have a project here in Escape. See, the information, data that we provide to them, it's very important for them as well. As partners, we work together as a team. Well, let's see if PHA is happy with the program or the work we are doing here. I don't think we will have a problem with other projects coming in. They will still come in to or we will have some more projects coming into this province to help them support the health issues here in the province.
Trying to liaise with the officer and see how we can help in that aspect. And it's good to just sit back as a manager and see the discussions going on WhatsApp and just, from time to time, just say hi.
The thing I really like mostly about the work is that, it's fascinating to study something that we didn't really learn specifically way back in the college. Okay, especially to do with malaria, we just learned generally about malaria. Getting to know deep within malaria is something that really fascinates me, especially in terms of research towards this project.
Thank you to the Strive team and our partners from Milne Bay Provincial Health Authority and the Escape Clinic. When we go there, it's a kingdom that we go to, and it's really great to have you join us on this virtual symposium and our partners from the National Malaria Control Program. So now from this, we're going to move on to our last two spotlight presentations. So the first up is Dr. Barne Willie, who's currently working in the background, supporting us with this the symposium to make it work. But he has recently graduated from completed his PhD, and he will present to us on the molecular epidemiology of Neisseria gonorrhea antimicrobial resistance in Papua New Guinea from a retrospective study. Thank you.
In this presentation, I'll be talking about my PhD research project. Before I dive into this presentation, I would like to acknowledge the Australian Awards for the scholarship, Associate Professor David Wiley at the University of Queensland Centre for Clinical Research for hosting me, and the Papua New Guinea Institute of Medical Research for their continued support. Gonorrhea is one of the commonly sexually transmitted infections, where in 2020 it was estimated that 82 million new infections have occurred. But the main concern with gonorrhea is that it has developed resistance to almost all antibiotics used in treating it. This includes the first line of treatment with amoxicillin, the second line of treatment with ciprofloxacin, and we are now left with cephalosporin and macrolide as the last treatment option. Because of this, the World Health Organization have recommended that surveillance must be done on a regular basis, and when prevalence reaches a 5% threshold, then a change in treatment must be considered. In Papua New Guinea, the prevalence of gonorrhea is estimated at 11% in 2018. However, we know that this may still be an underestimate because we continue to see a high prevalence of gonorrhea among the males attending STI clinics and among the female sex worker population. The diagnosis and treatment of gonorrhea in Papua New Guinea is based on symptoms, and treatment is with amoxicillin, augmentin, and azithromycin. However, in 2019, the new treatment guideline recommends cephalosporin as the primary treatment of choice. Unfortunately, that was not informed by local evidence. To fill this knowledge gap, we tested for genes and mutations associated with resistance to the main classes of antibiotics. We also determined the type of strains that are circulating in Papua New Guinea, and we compared that to the strains that are circulating in other population and geographic regions. We tested a total of 503 samples. The samples were self-collected vaginal and anorectal swabs among female sex workers, anorectal swabs and urine among men who have sex with men and transgender women. The samples were collected in Port Moresby, Lae, and Mountain Hagen. Looking at the prevalence of penicillin producing Neisseria gonorrhoeae strain, which causes resistance against amoxicillin, we can see that the prevalence have increased over time, where in our study we observed a prevalence of 88%. This prevalence is way above the 5% threshold. However, from personal communication with healthcare workers at the peri-urban and rural areas, they mentioned that amoxicillin plus augmentin has been working effectively for them. Looking at the prevalence of amoxicillin and cephalosporin resistance, we can see that the prevalence have decreased over time, where in my study we saw nothing, and we can say that there is no evidence of amoxicillin and cephalosporin resistance. For cephalosporin specific resistance, there wasn't any report in the past. However, in 2016, a prevalence of 1.5% was reported, but that study indicated that the interpretation of this prevalence must be made with caution. And in this study, we did not see any evidence. Therefore, taken together, we can say that there is no evidence for cephalosporin resistance. For azithromycin resistance, we did not see any evidence of its presence. For ciprofloxacin resistance, we can see that the prevalence have decreased over time. This may be due to the strict use of amoxicillin for treating gonorrhea. In my study, we saw a prevalence of 0.6%, which is way below the 5% threshold. However, that 0.6% was observed among the female sex workers in Lae. This emphasized the need for continued national surveillance to inform our treatment. The majority of the strains that are circulating in Papua New Guinea are unique, and of those that have been described previously, they were not reported in the neighboring countries to Papua New Guinea, which includes Australia, Vietnam, Japan, China, and the Solomon Islands. In summary, looking at the prevalence of mutations against amoxicillin resistance, we can see that the prevalence was low. Despite the fact that PPNG is high, we know that augmentin is still effective against these PPNG strains. For azithromycin, we did not see any evidence of resistance. Therefore, we could maintain the use of amoxicillin and azithromycin and reserve the use of ciprofloxacin and cephalosporin when we see prevalence breaching the 5% threshold. For the circulating strain, we see that the majority of the strains that are circulating in PNG are unique, which means that the sexual network in PNG is somewhat isolated from the regional and international sexual networks. Therefore, for public health preparedness and response, PNG must be advised by local evidence and not adopting guidelines that is based on regional and international data. The observed 0.6% prevalence of ciprofloxacin in lay emphasized the need for consistent PNGIMR surveillance in order to inform our treatment. And since we have been using molecular test for this testing, we see that molecular testing is a valuable tool that can be used to complement drug susceptibility testing by culture to enhance surveillance in the country.
Thank you, Dr. Barne Willie, and we are very proud to have you join us at PNGIMR, and congratulations again on your completion of your PhD. So our next spotlight presentation is by Ms. Dulcie Lautu. But before I go, I just want to acknowledge some of our partners who joined late. One of them from Madang, joining our Madang team, President of Divine Word, Professor Gibbs. Welcome, and thank you for joining us for the afternoon session. So moving on to Dulcie. Dulcie is from the vector-borne diseases unit, and she is nearing completion of her PhD, and we cannot wait to have her back to join us. But today she will talk to us about investigating molecular markers of anti-malarial drug resistance in PNG. Thank you, Dulcie.
Hello everyone, my name is Dulcie Lautu and I am completing my PhD through the University of Melbourne. I work across 3 institutions, Burnett, Deakin University in Geelong and Weehai, but I'm mostly based at the Burnett Institute. So today I'll be giving a snapshot of my PhD research project, which involves investigating markers of anti-malarial drug resistance. PNG aims to eliminate malaria by 2030. However, there are many challenges to achieving this goal, and one of them is parasite drug resistance. Drug resistance is a serious threat for malaria treatment, especially because malaria parasites have developed resistance to all available malaria drugs, including the current WHO standard treatment for uncomplicated malaria, known as artemisinin combination therapy, or ACT. Now, while ACT remains effective in many malaria endemic countries, including PNG, it's under threat due to the rapid spread of artemisinin-resistant parasites. When we talk about artemisinin resistance, it's characterized by a delay in parasite clearance after an infected individual is treated with ACT, and it's known to be associated with genetic mutations that are found on a gene called the CALCH13 in Plasmodium falciparum. There are 20 mutations in the CALCH gene that have been validated in artemisinin resistance, but the most common is the C580Y, and it's become a very useful marker for detecting and monitoring resistance. So in 2011, PNG implemented ACT as first-line treatment for uncomplicated malaria. Immediately after, in 2012, the first reported case of a drug-resistant infection was identified in an Australian who had travelled to the West New Britain province. In 2016, in a small clinical trial in Wewak, East Sepik province, 3 patients were identified to carry infections that had the C580Y mutation. Genomic analysis to determine the origins of the Wewak isolate show that they share similar genetic backgrounds with drug-resistant parasites from Cambodia. However, they had far more similarities with PNG wild types. A closer look at the relatedness to other populations, as shown here in this phylogenetic tree and indicated in the yellow strokes, that on topology they seem to cluster with the Indonesian population, but in fact they lie halfway between Indonesia and PNG parasite populations and a bit more distant from the Cambodian population. So these results suggest that the Wewak mutants had either emerged on a hybrid PNG Indo background or have some Cambodian ancestry imported into West Papua and then extensively recombined with the Indo-PNG parasites. It's important to note that this is only for 3 identical samples, and currently analysis is ongoing to determine this with more parasite data. These findings are critical for PNG, and it signifies this heightened effort needed in drug resistance monitoring. And so this leads me to the aim of my research project. My project has 3 main aims. Aim 1 was to determine the prevalence of artemisinin-resistant markers in PNG. Aim 2 involved developing assays for detecting drug-resistant markers and further exploring drug-resistant genotypes in Madang and East Sepik parasite populations. And Aim 3 was to determine the longitudinal changes in Plasmodium falciparum population structure and drug-resistant genotypes over time. And this is in the context of the use of ACT in the East Sepik province. In the interest of time, I will be presenting key results from Aim 1 and highlight some tools that we've developed in Aim 2. So to determine the spread of the artemisinin-resistant C580Y mutation, samples were analyzed from different studies, locations, and time points. So basically anything in red in the pie chart is a C580 mutation. Anything in light blue is a wild type. And so the take-home message from this is that the C580Y prevalence is increasing in the PNG parasite population, as seen from the 3 different maps. I'd also like to note that an updated report on the prevalence of C580Y will be presented by colleagues from the Molecular Hub in the upcoming PNG Medical Symposium. I'd like to conclude with highlighting 2 tools that have been developed for monitoring drug resistance. The first one is a qPCR assay that I developed to detect the C580Y mutation, and this is being used as a rapid detection method currently being implemented in the Molecular Hub in Port Moresby. The second assay is a multiplex drug-resistant amplicon assay, and this assay has been adapted to be used on the portable nanopore sequencing device, and it has been transferred to the Molecular Hub. As with any sequencing approach, bioinformatics pipelines are very important and needed to analyze sequencing data. And I've been very fortunate throughout my PhD journey to be supported by amazing colleagues who have been able to develop these pipelines for use. Not only have they developed pipelines, but also developed an R-Shiny app that any novice researcher can use for analyzing drug resistance sequencing data. And this will become very useful for in-country molecular monitoring of drug resistance in the future. And with that, I'd like to say thank you for your attention. I'd like to acknowledge everyone that's contributed to this work, collaborating partners and funders. Thank you very much.
Thank you, Dr. Willie and Dulcie. Thank you for your wonderful presentations. And that concludes our sessions. And now, but before I move on to, we have one question, and please reminder again, if you have any questions, please post them or flag them so we can come to the site. And then just to acknowledge that we have some members who joined a little bit late from Port Moresby, the National Planning Department, Finance Department staff, and the NCDPHA staff, as well as Hola Clinic staff. Thank you for joining our team in Moresby and making time to join us, considering you all have a lot of work to do. So thank you for joining us. So I will... So we have one question so far, but again, let me remind you, we can come to each side. So please think of the questions and ask them. But we have one question that we can start off with. So after the questions, then we will go back to Professor Pomat, who will then do the closing remarks for us. So the question is directed to Dr. Barne Willie. Is there a potential of having a centralized surveillance of all drug resistance for all pathogens? Thank you, Doc.
Thank you, Dr. Ome, and thank you, everyone. And rightfully, the question is, it's a big one. And I think going out and coming back again. We have the human capacity and also the facilities that we have here, both up in Goroka and in Madang, that they've been doing work on drug resistance and all that. We have the capacity, and if we can, upgrade the facility in some form and ways, but we don't have to forget that we already have the system like the traditional PCR, because I'm talking from a molecular point of view, background. So we have the facilities, and as long as we have whatever it takes for us, and if there's the priority, from the government says, okay, this is our priority, then we can do it. And not forgetting that, the WHO have already listed, the priority pathogens that we have to work into. So definitely the IMR has the capacity, and we can do that, given, all the capacity that we have, both in, sexual health and in malaria. We can, put that together to do something for the Institute, for the country, and the globe as a whole.
Thank you so much, Dr. Willie. So like building on that, there's already capacity where through the vector-borne diseases unit, we are doing surveillance of all the other systems, infections, and then we have the surveillance unit that is looking at all of that. So there is opportunity, and I do agree with you on that. Thank you, Dr. Willie. So now that's our one question. We haven't got any questions from anywhere. So from me, I want to say thank you, everyone. Again, Joseph and Gwen, Sarah, Barne, all for the support, Enrique and Peter. I will now pass it on to Professor Pomat to close off for us.
Thank you, Dr. Ome, for being a wonderful host. And thank you, everybody, across all sites, online, offline, and everywhere in between. Thank you very much for taking part in this 4-hour session of the virtual symposium. We appreciate you giving away 4 hours of your time to come and sit with us and learn a bit more about what we're doing at the Institute. I think we learned a bit about clinical trials. We learned a bit about surveillance. We learned a bit about building partnerships. Professor Homer told us something about equity. And so we learned a lot, and we've got some young talents that are coming along as well. So it's been a good journey over the last 4 hours. I hope you enjoyed it as much as we did. I hope you learned something, and please go to the forums on our website to tell us where we can improve for our next virtual symposium. So with that, I'd like to once again thank everybody, in particular the Pathogen Coalition partners who finance this event from happening. We'd like to thank DFAT for also being part of the Pathogen Coalition that helps us to fund this. Webcast Cloud, Joseph and your team, thank you very much for doing this for us, and all the staff of the Institute who have contributed one way or another to ensuring that our partners went to each of the different sites and enjoyed viewing, as well as enjoyed some lunch with you. I hope we can continue to build on the partnership, and the research will continue as well into the future with the help of you, our partners, and all the partners as well online. So thank you very much, everybody. We'll hope to see you again next year.